Hello.
We are not getting any audio.
Good morning, everyone. Welcome to the final day of BIC 2020. Thank you all for joining. We want to start the session with the first session of unexpected complications in simple cases, missing the invisible dragon. For that, I'd like to call the moderator for the session, Dr. Sameer Gupta, who's the Director of Cardio Cath Lab for Metro Group of Hospitals. Welcome, sir. Handing over the session to you.
Thank you so much, Shantanu. I'd like to welcome everyone over here for the first session of the last day of Best Interventional Cases. The topic for today is unexpected complications in simple cases, missing the invisible dragon. Now, I know in interventional cardiology, whenever you have a conference, the complications section is probably which is the most well attended. Everybody's always interested to see, we all have complications. How do we get out of it? And over the next 2 hours, we will probably go through a lot of these complications, about 9-10 cases, and we'll see how some of the people were able to get out of it. I would like to introduce our chair people, Dr. Praveen Chandra. He's joining us from Gurgaon. He's the chairman of cardiology for the Medata Hospital. Dr. Hakim Benawar is joining us from France. He's the chief interventional cardiologist over there. The other panelists, I'd like to welcome both of you, Dr. Chandra and Dr. Benawar. Welcome. For the panelists, we have Dr. Amar Singhal. He's the head of department for Sri Balaji Action Medical Institute. Dr. Apurva Vaswada. He's a senior interventional cardiologist at TriStar Hospital in Surat. Dr. Prashant Jagpat, he's the director at Viveka Hospital in Nagpur. Dr. C.N. Makhale, he's the co-director of the cath lab in charge at Ruby Hall, Pune. Dr. Ajit Bhagat, he is the director of the cardiac cath lab and interventional cardiology for Kalannayan Bajaj Hospital in Aurangabad. And Dr. A.B. Malpani, he's the senior interventional cardiologist for B.M. Birla Hospital in Kolkata. And Dr. Harminder Singh, he's the interventional cardiologist in Mumbai. Welcome all the chair people and panelists. We have some interesting and good cases. I think let's start off with the first case. Dr. Riaz Mujawar is going to be presenting the first case of complicated BNV. And he's joining us. He's the senior interventional cardiologist at Bharti Hospital, Sangli, and the head of department at Wanless Hospital. Dr. Mujawar, on to you.
Dr. Gupta, I don't think Dr. Mujawar has yet joined. We can move on to the second presentation, which is of Dr. Jimmy George.
Sure. The second presentation is, so we'll take Dr. Mujawar's presentation later. Dr. Jimmy George, he's a senior interventional cardiologist in Lissi Hospital in Kochi, and he's going to be presenting a case on bolt from the blue. Dr. George.
Yeah, sure. Okay, is my screen visible and am I audible?
Yes.
Okay. A warm good morning to everyone. It's indeed a pleasure for me. I'm Dr. Jimmy George from Lissi Hospital.
Your voice is low.
Kerala. I thank the Translumina for giving me an opportunity to present at the PIC.
George, can you speak a little louder?
My case, bolt from the blue. So this is a 65 years old gentleman with not much comorbidities who had presented with effort angina of few weeks duration. Investigation in the form of stress testing was positive at 9 mets. He did not have any regional wall motion abnormalities, and he had a fair LV function. This angiogram was done elsewhere, which had shown a significant left main disease. This is angio, which we did after taking in for a procedure. We had a significant distal LM, 60% disease with an ostial LAD of almost 70 to 80% disease. Ostial circ was involved, and the distal circ had a 40 to 50% disease. We'll just show his spider's view and also the cranial view. What was interesting was he had a small aneurysm at the proximal mid-LAD junction with two early diagonals bifurcating. He had a right coronary dominant system, which was comparatively normal. So considering the distal LM disease at a wide angle, it was thought of a relatively not that complicated LM bifurcation. It was thought of going for a TAP procedure. Also planned of covering the mid-LAD section also in view of some small diffuse disease, because the entire distal LAD looked larger in size and free of disease. The ostial circ to me looked significant, thought of tapping it or planned for a LM bifurcation after a Gaussian stent. So LAD was wired and measured. A 3x48 drug-eluting stent was positioned across the proximal to mid-LAD position. It was deployed. Post deployment had shown good results. This was followed by an overlapping 3.5 into 28 drug-eluting stent from LM to the proximal LAD, covering the first stent or the distal stent, which was well confirmed in the LAO cordon view. There was overlapping between the stents. And, oh, sorry. Step, please. Already explained. So this was the first stent, followed by the second stent. And this was the placement of the second proximal stent from LM to LAD, 3.5 into 28. Then the stent balloon was advanced distally to the overlapping segment and also was well dilated to 14 to 16 atmospheres. And this was the result after the two stents on LM LAD and mid LAD. I thought like there was an impinging of the ostial LAD, though it looked normal. I thought it's better to recross the wire and see for any. Yeah, this was the distal recross, and a balloon dilatation was done with a 2.5 into 18 balloon over the ostial LAD, ostial circumflex. Followed which I thought the ostial circumflex looked significant. So a 3.5 18 drug-eluting stent was implanted with a balloon in the proximal LAD. I forgot to say there was a port also done with a 4 into 8 balloon before the crossing, and a 3.5 into 15 balloon and a 3.5 into 18 balloon was kept in the LM with the proximal LAD and circ, and a simultaneous kissing balloon dilatation was done. And this was the final result. Looked like a fantastic result at this stage, and I thought like I'd remove all the balloons and the wires and finish off the procedure as any simple angioplasty. But Barry, this is an LM bifurcation, you should be quite careful of. Meanwhile, I noticed the patient developed a severe chest pain followed by a sudden collapse. This is what happened now. His BP started falling down. His pulse rate almost went up to below 25. And I had almost pulled the circumflex wire back anyway. The balloon was already out anyway. Just have the LED wire and the balloon. And I took a shoot and I saw like almost the entire contrast being completely extravasated into the pericardium or into the vessels have been just opened up. It's a massive operation. So the patient was almost standstill, was asystole. It was followed by pushing of inotropes, adrenalines, and at the same time, CPR continued 5 to 10 minutes. There was no response. It was just a tickler flow across the circ and LED, rather a TIMI 0 to 1 flow only out there. Almost you can see the cardiac standstill on the right side. But fortunately, the effort of all other medical staff in the cath lab and the CPR team, patient was revived in another 10 minutes time. And fortunately, we could take some shoots and see a lot of pericardial effusion coming up. There's a perforation. I'm not sure where this perforation is from. Is it from the left vein, or is it from the circumflex, proximal circumflex, or from the proximal LAD? Seem to be a total chaos of confusion all around. Thought of a left main in the beginning, and the left main dilatation was done without anything. The previous shot showed a significant leak from the circumflex, hence the balloon was kept on the proximal circumflex and dilated at high atmospheres. But you can see on the left side, still there's a extravasation of contrast. So another balloon was taken, keeping the balloon in the circumflex. A second balloon taken up in the proximal LAD and was dilated for almost 5 minutes. You can see some decrease in extravasation from the proximal LAD. It was confirmed it was from the proximal LAD. This was followed by prolonged dilatation for 15 to 20 minutes. Meanwhile, there was enough fluid collection around the heart to cause more fall in BP, and the pericardiocentesis was managed by the time, and significant amount of blood was taken out, followed which the patient stabilized a bit. The right side, if you see, you can see the shoot over there after the balloon deflated with 20 minutes dilatation. You can see almost the perforation is healing up. This was followed by another 15 to 20 minutes dilatation. If not settled, was planned for a covered stent over there. But fortunate enough that the perforation had healed over there, and the LAD was showing a significant TIMI 2 to 3 flow. This was after more than 30 minutes of occlusion, and this was the caudal shoot at the LM bifurcation area. The LM side, the proximal circ looked normal and it looked better. This was followed by now a small kissing dilatation, rather a soft kissing dilatation because of the strut injury or strut overlap to occur. So it's and this was the final shoot after almost 2 hours of waiting. There was a hemodynamic fall in BP also. So and temporary pacing and then IABP support also was taken. Indeed, it was a ball from the blue. He was shifted to the cardiac care. It was on mechanical ventilation, balloon support, pacing, and pericardiocentesis was continued till any drop in BP was settled. Unfortunately, he developed acute tubular necrosis, went into septicemia, shock. CRRT was started. Almost for 1 week, he didn't pour any urine. But after a week, he was fortunate enough, or I was lucky enough that he started pouring urine out. He was extubated and discharged in 10 days' time. So that's my case. Thank you.
Oh, that's definitely a save. Any comments from the panelists?
Yeah. So I think let me start the discussion on this case. Can you hear me? Yeah? Okay. So basically this patient was very well managed. I must congratulate Dr. George, that he did a very good job. He detected the problem immediately and started acting in the absolutely sequential way, because that is the sequence we have to follow in these kind of situations. And the main issue is, why did it happen? And of course it is, to me it is clear that it was because at the time of last kissing dilatations, it's happened soon after that. So maybe that the proximal part of the lady, which was actually the culprit in this case to me, because of the high, this was a 3.5 balloon, must have gone to very high pressures, and that could have been the reason for that. And maybe when you're doing a kissing, sometimes the expansion of the balloon may happen more in the distal part, which is not compressed from the other balloon which is kissing it. So that may be the possibility. However, he had already done with a 3.5 stent earlier, and vessel was looking reasonably 3.5 proximally. So it was not a wrong choice, but sometimes these kind of things can happen because of the difference in the wall architecture. Maybe there was some calcium spur or eccentric calcification in that area which led to this problem. So that is about the perforation part, the mechanism. And of course, dealing with these perforations is the sequence remains it's quite, step by step, that you have to immediately do a balloon tamponade, which he did, and tried to figure out which side was that. That was very important. That first he dilated in one side because it was not very clear to start with. And at that time, when there's so much confusion in the lab, the patient is collapsing, it becomes really difficult to make out where it has collapsed, especially when you have done a bifurcation. So site of perforation is certainly is one of the issues which happens many times. Even if it was a LED, sometimes you're not sure in a long stent where is the site of perforation, where should you put the covered stent, where should you do the balloon tamponade. So that was smart, doing the sequential balloon dilatations and then trying to inject and figure out. And then, of course, the last part is very, very important, that you have to be very patient. You have done a good job, finally, you have sealed, but taking care of the patient in the next week and 10 days is also very important, because I have seen patients being lost because the sepsis was not handled carefully, the ATN was not handled carefully, and that can happen. So I think, more or less, I will say everything was done rightly, and at the end of the day, the patient survived. That's the most rewarding thing, especially in these kind of extreme. I will say this is extreme complication. Although most of us have seen it, but certainly when it happens, it is like you just don't want to have it again. So that's my comment on this.
One of the things we always ask ourselves in these complicated cases is that if you were to do it all over again, could you predict it? Would you do anything differently?
Yeah, for me.
Yeah, I mean, in general,
Yeah, actually, I would have definitely thought about it doing differently. In the sense, like I would have thought of putting an imaging as such, like an OCT, to see first of all the small aneurysm, how much the wall weakness is first of all, and definitely to see for the osteocircumflex whether I definitely need to put a second stent. If at all there was a stent across the LM LED crossover, after stenting, I would have put an OCT and seen if at all any stent joint is there across the ostium, because the ostium angio-wise to me looked doubtful anyway, and OCT would have confirmed it. And if it at all, the joint would have been opened with the balloon dilatation, and would have done a re-OCT over there. And if the orifice or the ostium or the circumflex is free of disease, I would have just left it alone. And the thing is, I would have even done a FFR over there to the circumflex. I would have done a soft kiss after this, not a hard kiss like this.
Yeah, I would absolutely agree with what you're saying. That circumflex ostium, probably, it could have been left alone. But as you said, that's an afterthought.
Yeah, it's retrospective.
Yeah, another thing which I have seen is, such patients when they have relatively normal LV function, when they're non-diabetic, and when they're relatively young, the chances of these people coming out of such a catastrophic complication are a little better. And I think your patient was non-diabetic, its renal function was basically normal, LV function was probably reasonable. And he, how old was he?
He was 65 years old. Only that thing
65.
was
So
there.
it's not done.
65
Yeah,
years.
that was the only thing.
Only
So
thing, and
I think this was a very well managed case, as Dr. Chandra said. It's extremely lethal complication, very well managed.
Very good case and very well managed. You saved the patient. I have one question before. In your angioplasty, did you perform any POT, proximal optimization technique for the left main with the biggest balloon?
Yeah, 4x8 was done before crossing the ostial circumflex with the balloon, with the wire side. So this thing was there, but during the presentation I had told anyway, before crossing the ostial proximal LM was dilated with a 4x8, then the crossing was done.
Okay, so another question is when you have an aneurysm like you had in the on the LAD, maybe to manage the diameter of the LAD, what do you think about the intracoronary imaging? Because with the angio, sometimes it's very complex to determine the real diameter of the LAD.
Exactly. And imaging like an optical coherence tomography would have really helped, not only for seeing the aneurysm, the musculature of the aneurysm, as well as the septal and diagonals which arises nearby anyway. And also the ostium of the circumflex and the left main at the carina area would have been well visualized over there, the size of the stents, and even after stenting the post-dilatation, how much required, or whether it required a second stent over the ostial circumflex also would have been clearly made out in the optical coherence tomography or an IVS imaging. I would have suggested OCT would have been a better choice. Any bifurcation definitely needs an imaging support also.
I agree with these comments to start with. I mean, one part was how to deal with this kind of complication. The second part is how you would have proceeded from the very beginning. I completely agree that imaging, if you are doing a left main bifurcation especially, and you are not very sure to start with that you want to do a circumflex or not, of course you have to be ready with the FFR because in here you started with one wire only. And that means in your mind, you had the idea that you will finish off with one stent. And this was completely provisional for you, right? So,
sorry to interfere, sir.
Because you did not.
I was planning a.
So what I would have done differently in this, I would have put a wire from the very beginning, and maybe in some patients, in fact, I did one case during a live in LISI itself many years back, and I don't know whether you were there or not at that time. And we put a FFR wire in the side branch while we were treating the circumflex, so that we get an online view what is happening. So with every step, you know what's happening to your circumflex, and then finally checking out with once you give nitroglycerin, you take the final figures. If everything is okay, pull out, no complication. And that's what we did in that case. And that was, I think, at the time when very few centers were doing FFR. And in fact, there was a discussion whether FFR is such a safe thing or not, but now we know it is safe. So putting a FFR is also a very good idea, because otherwise, if you are thinking if this was little more significant in your mind at that time, I would have gone with 2 wires, definitely, and of course treat it like a bifurcation. From the
definitely, sir. Well taken, sir. I would have also thought of doing an FFR even after opening the struts, if at all that was significant. But unfortunately, to my laziness or my haste anyway, this patient was planned on a Friday. His insurance did not come up, and he was posted on a Saturday. Saturday half day, weekend, everything happens in a rush anyway. It's a big mistake. Anyway,
it always happens like that.
Take your time. Yeah, that happens on weekends only.
That you want to go home in 5 minutes.
Yeah. right. Simple bifurcation, but never even an angiogram or a temporary pacing is never simple anyway. You learn everything from even the smallest thing.
I would like to know the opinion of other experts that, particularly this circumflex ostium is pretty notorious. Sometimes, in terms of assessing the severity, many times you see that the lesion looks, pretty significant, and FFR is negative on many occasions. So would you, as in such cases as a routine, do an FFR before deciding your strategy?
Not really for me, because we had to open the strut just front the circumflex in the strategy of stenting this bifurcation. But in case of a lesion after doing the kissing, maybe you have in some cases you have to do FFR to be sure that the lesion is not really significant. But in our strategy, it will not change really the strategy if you have only a small and tight stenosis on the circumflex. We will try to do a provisional T stenting in this case.
I just want to add a few things. There are a lot of questions coming in from the audience. There's a question.
I have to add. I have something to say. Can I intervene? Yeah. Hi. Always we blame something wrong with the balloon pressure or the balloon sizing, but is there anything to do with the stent itself in risk of perforation? Because nowadays more and more thin stud stents are coming. And is there any role of the thin stud in perforations?
No,
let me say that sometimes it has happened because of the fracture of the stent struts, and then when you are already at a high pressure, that strut, once it is fractured, it just goes out and it can perforate. So that's what I think you are trying to say, right? Yeah.
Right. Yeah.
There are a lot of questions coming in from the audience. I just want to put them out there, so we can talk about it also. The audience, one question which has come up from Santosh, Dr. Santosh at KEM is, have you reversed anticoagulation? And was any heparin reversal done? Also came from Indus Hospital. And the second question, we've answered a lot of the other questions. The second question which came up is prolonged inflation for 30 minutes is quite a lot. At what point were you thinking of going to a covered stent?
Yeah, actually, reversal of heparin was definitely kept in mind anyway, because things like this was a critical area of LM bifurcation. So even the thrombosis formation also was definitely thought of anyway. So protein was kept in hand anyway, but was not given. After the 15-20 minutes dilatation, there was a regression in the perforation, and that gave a chance or gave a way for us to just wait to giving protein for some time anyway. And definitely after 30 minutes, there was no significant extravasation, so protein was not given. And the thing is, like prolonged dilatation would have its own injuries. And covered stent was kept ready in the shelf anyway. If was planning to put a covered stent across the proximal area.
So regarding the reversal of heparin, let me just add here that it should not be done while you are proceeding with the complete steps, and then it can lead to more complications leading to thrombus formation, etc. So we have to handle the mechanics part of it first and then see the drug part of it. Now let me just say, tell Samir, you are moderating. It is already half an hour, so please keep timekeeping on. Otherwise, I mean, these are such interesting cases we can discuss for 1 more hour.
I know, yeah, this is definitely. So I think I will definitely take your cue and move on to the next case. Dr. Chandra, thank you for pointing it out. Dr. Mujawar has joined us. Dr. Mujawar is going to present the next case, which is a complicated BMD. The senior interventional cardiologist at Bharti Hospital, Sangli, and the head of department at Wanless Hospital. Dr. Mujawar.
Dr. Samir.
Yeah, good morning.
I'm next, or somebody else is presenting?
I think Dr. Mujawar, I was told, is joined.
Yeah.
He will be presenting.
Yeah.
Okay.
Good morning.
Okay, fine. I'll do next. No issue.
I don't see Dr. Mujawar over here.
So let him do.
Let's continue to the third presentation. The third presentation is by Dr.
Can you hear me?
Are you?
Dr.
Yes, Dr.
Mujawar.
Mujawar. Yes, Dr. Mujawar, please go ahead. We're waiting for your case.
Able to see my slides?
No.
Oh, share a screen.
Yes.
Coming.
Now?
Yes.
Good morning. Myself is Dr. Riaz Mujar. I'm an interventional cardiologist. I'll do both structural heart diseases and routine coronary intervention. Today morning, I'm going to share the 2 cases of balloon microholotomy, which leads to complications. Also, I'll show the sequence of the balloon microholotomy, what are the steps in the balloon microstomy, and how we tackle both the complications. The angio images are combined the image of both the patients to get a correct sequence, because all steps are not available for each patient. My first patient is a 27-year female with a severe mitral stenosis with a severe pulmonary hypertension, and she is a 60 weeks pregnancy. So because of she is having a severe mitral stenosis, severe pulmonary hypertension is a high risk pregnancy, and we plan for the balloon microholotomy of this patient. This is a echo image of this patient. There is a significant gradient across the mitral wall, and the mean gradient is around 14 millimeters of mercury, and peak gradient is 23 millimeters of mercury. This is the first we taken the pigtail, and pigtail is positioned into the non-coronary cusp of the aortic wall to get the lowest position of the aortic root. Then we're trying to put a Mullen sheet to the left brachiocephalic vein. Yeah, Mullen's wire went into brachiocephalic vein. Then we taken the Mullen sheet. This patient is having a significant IH bulging, so we're expecting the tamponade in. So tamponade sheet was ready for this patient because this was a very high risk case. And this is the bulging septum. You can see the staining of the interarterial septum, and we're trying to puncture, and we successfully able to puncture of the interarterial septum. This puncture is for the another case. Just I'm showing here the for this. This is the ideal. This is the pigtail at the non-coronary cuffs, and this is our the puncture needle. Ideal puncture site in APU should be at least 1 or 2 centimeters below the lower end of the pigtail, or in between the vertebra which is below, which is the ideal position for the puncture in anterior view. We have to see also in the lateral view. Generally, in lateral view, the puncture point should be at exactly midway between the spine and the pigtail. So we can able to puncture with a contrast. And this patient is developed tamponade. This is showing the we are dilating the interarterial septum with a dilator. Because we all patient is developed a tamponade, and we already dilated the septum, and the patient is pregnant. Okay, so without doing a balloon microholotomy, there's only option remaining for patient is going for a surgery with bioprosthetic valve. So because already sheath and everything, already the wire in the LA wire is in the left atrium, we taken the decision. We first put the pigtail for the deadening of the pericardial tamponade, and then we passed the balloon and we completed the DOME. Slight delay in the videos. Sorry for the interruptions. See, this is pigtail in the position. Yeah. So this is the this is a significant gradient between the and this is a post procedure. Almost this gradient is come to 0. The mitral area increased to 1.7. There is some 2+ MR is there for this patient, and this is gradient is mean gradient is come to 6 millimeter of mercury. So this is my first case. So 27-year pregnant female with a 16-week of pregnancy with severe mitral stenosis. So we planned for the balloon mitotomy, but during the procedure, patient developed, because IS is significantly bulging, almost touching the, you can see the 1 centimeter gap between the intertidal septum and the lateral border of the heart on the angiographic. Okay, but able to puncture successfully, and because LA wire and dilatation is done, so we completed the BME. And this is the second patient which develop a severe MR, and patient is hemodynamically unstable. So the intraarterial septum is dilated on table because of the to reduce the LA pressure and to reduce the pulmonary edema, and the patient is sent for the surgery. So both the patients, the second patient required open heart surgery with mitral valve replacement. But first pregnant patient, in spite of developing the cardiac tamponade, we able to do the pericardial synthesis. We done the atrotransfusion by taking the left venous puncture. Okay, and after the successful, after doing a when we achieve the drain all the pericardial blood, we able to do DME, and then we reverses the heparin by giving a protamine. And the patient was intubated during the procedure, but after 4 hours, we successfully able to extubate the patient, and patient does not develop a recurrent pericardial effusion, and the picture was kept for 24 hours, and the patient was successfully discharged on 4th day, and patient underwent a normal delivery. Thank you. And the second patient which was there was that is also a there is a routine. The score is not much. Wilkins score is 8. The puncture is also very good because the second puncture of that patient, but developed a significant MR, and the BP was falling like anything. And we want some time. The patient should be surgical OT, and that's why the intraarterial septum is dilated with the same balloon. Okay, almost we dilated up to 10 centimeter, and because of creation of the connection between the right atrium and the left atrium, there is some time we got, and the patient was successfully underwent a mitral replacement.
I think that's
yeah. Yes, sir.
I think that was a great case. Dr. Bhagawat, any comments? What do you think?
So I think, this was wonderful. And I must request, I can see Dr. Makle sitting here, a lot of, very experienced people. So Dr. Makle, how are you? So
I'm good, but I can't see anything. I don't know whether you are able to see
anything.
Huh?
Okay.
Sir, you are visible to us, all of us.
You are visible. And any case, maybe we have Dr. Ramesh is here, and Dr. Harminder Bhagwat. So Dr. Harminder, please go ahead.
Yeah, in the first case, I think the place where the LA got ruptured was when the dilator was being passed through the intraarterial septum. I
Yes.
thought the wire was too high and the dilator was probably touching the roof. That's a very important place where tamponade can happen without us realizing. And in the second case, I want to ask the operator, where is this balloon actually? Is this a balloon which has already come out and this thing, or
no, sir.
What was the mechanism?
Case, I'll show this slide once again. Second case, sir. Sir, this is across the intraarterial septum. This is in the LA. Okay, this is there is a waist is there here, which is intraarterial septum, and we dilate it in the RA. So it is across the LA and RA, across the intraarterial septum. Okay, so that decreases the left atrial pressure. Okay, and that gives the time, and during mitral valve replacement, they repair the intraarterial septum. This one.
Okay, Mujawar.
Yes,
can all of you listen to me?
Yes,
Yes, sir.
Dr. Mujawar, please go ahead.
You have done the case, managed it very well, but my only one problem is this girl is 16 weeks pregnant.
Yes, sir.
So what are the medical legal issues you are going to face?
So one is that radiation-induced fetal damage, which already explained to the patient. Okay, and if required a severe, because that is a severe MS, very high risk case, IS is significantly bulging, and so if the patient require a mitral replacement, then there's a harm to both mother and baby. But between 12 to 18 weeks is the ideal time to do the BME in this case, with 3 to 6 months. And if you don't do the BME, that will be very high risk pregnancy, and patient can require a BME in the last trimester, and that time chances of abortion is very high. So we give only protection covering the shield, abdomen, both.
Yeah, I agree, but there can be legal repercussions of this.
So already we taken the
fetus, which is more prone for the
already we taken the consent, explain the what are the complicated radiation hazard to the baby, and
once we take
that is one. Point number two,
class 1 indication is there to doing a severe MS with during 4 to 6 months if there is a pregnancy. Even if the wall is not suitable for the BME, we can give a chance to do a BME instead of sending for
the mitral. But here, with the PA pressure of 17, those gradients, I think we could have still managed for another 4 weeks and could have done legally good. Point number 2. About the perforation, as Harminder has pointed out, that while you are pulling down from the SVC to RA, at that particular point, your needle in a one view may be pointing correctly, but other view it was not, and that is why it has punctured the gone into the pericardium.
Yes.
So whenever you are doing, and this particularly happens when you are doing this type of patients who are the pregnant. Because you are mentally blocked, you want to keep the radiation minimum. So your movements are very minimum. And you try to sort of, juggle it at that particular time. Because you are not mentally comfortable, you are not that confident, which otherwise it is. So this invites for the trouble. If possible, this can be avoided with the transesophageal echocardiography simultaneously, where you can see the intra-atrial septum very well, and it reduces the radiation also. See, ideally, theoretically, you should have the ICE catheter, but ICE catheter is not easily available in the country. But I would have preferred here to do it with the TE guided puncture rather than doing it under the fluoroscopy. Means it would have added more safety as a lesson. Harminder, do you agree with this?
Yes, sir. Absolutely. In fact, sir, at every stage, at the time of puncture, at the time of dilatation, we must pause for a minute and observe the blood pressure before we go on, especially in such a critical case like a pregnant lady. And I think if you observe that, we'll be able to avoid. And each and every step has to be very deliberate and very, very thought out in such an important case. And there should be no hurry or any such thing during the procedure. As it is fraught with so many complications. I think the time of injury was when the dilator was passed into the left atrium. It has probably hit the roof.
Correct.
And that is probably was little avoidable. And too much of the LA wire is coiled inside.
Too much.
So we should avoid that. And I think that was the place where we could have taken a little extra care. It was nice that the case was finished, because leaving such a case unfinished without BMV would have been further complicated the issues. It was nice that it was managed well, pericardium drained, and the BMV was completed. That was a good thing to do.
Just one comment. Whenever you have a pregnant patient, your standard what we call standard parameters for detecting the septum, the standard landmarks for detecting the septum, the proper site of puncture are distorted. So we should never go by the standard landmarks in pregnant patients, because the diaphragm is pushed up, the anatomy is distorted, the septum bulges. So in that situation, what I generally do in pregnant patients is, in lateral view, you inject and look at the horizontal flush of the intra-atrial septum. And then, depending on how it looks, it rarely looks horizontal in pregnant patients. And then you decide about the site of puncture. Because many times, if you use standard landmarks in pregnant patients, there is high likelihood that you will go wrong.
Yeah, there actually the TE will help you, the intraoperative TE.
Yes, it does.
Yeah, I think this is a very, very important comments from all of you, that tea may be a good idea and is a good idea, but certainly many of us have done without teas and so many years, year on year, and but the only important issue is, which somebody pointed out very rightly: don't be in a hurry, don't be in a rush, take your time, step by step, don't panic, and it'll be fine. I think with this we should move to the next case,
Yeah,
because it's already
yeah. Running short
10:50.
on time. The
Yeah,
next case is
please
going
stop.
to, yeah. The next case is Dr. P. Manokar is going to present on never ever ever give up. And Dr. Manokar is.
Yes, good morning, sir. Nice to see you all on this webinar platform. Doctor, this is a very simple case compared to what Dr. George showed and others showed. This is a far simple case, but I put it up because I thought usually we think it is simple and how things happen. So this is a 60-year-old male who came to the hospital. Actually, my colleague, in fact, my assistant saw the patient. He had evaluated, he had admitted under for intervention. He had worked up the patient, and patient had single vessel disease. So he informed me that he's doing the procedure. I said, he shared the images. I said, just a 2-minute job, so why should I bother about it? So I asked him to proceed with the case. Next. So, so this was like a very straightforward case. Please click on the images, videos. No, go back, click on the video. Click on the video. The next video, adjoining video. So it was like a kind of an eccentric lesion in the mid LAD. Hardly, in fact, in some of the views, I was not even convinced that please play that video again, second video. I was not even convinced that the lesion is very tight. But my colleague who was supposed to do the procedure, he thought it's significant. Since he knew the patient's history and background, he thought it is definitely a significant lesion. So he proceeded with the intervention. Next. And I also finished my work and left for home. Next. Click on the videos. Please click on the videos. Next. So it looked like a routine walk in the park kind of PCI. Next slide. Click on it. In fact, one of my colleagues always used to say, direct stenting is a sign of laziness, and this is a learning point with this case. Please click on that video. So he took, I think, 2.75 into 28 millimeter stent and went ahead to directly stent the lesion. Click on it. Right. Go to the next slide. Obviously, the stent did expand. Click on it. So he tried all things. He deflated, inflated, did it 3 times. It didn't open up. Then he thought, okay, he will use a non-compliant small balloon and open it up. So the first mistake that he did is, since this was a 2.75 stent, he took a 2.75 into 8 millimeter non-compliant balloon to try to open up that unexpanded portion. Next slide. Next slide. So you can very clearly see that despite the fact that this balloon, this is just the stent boost to show that how the stent is under expanded. So he tried a lot with a 2.75 balloon, it failed. Then he took a 2.5, it could not cross. Then he tried a 2.25 balloon, which crossed the lesion, but definitely did not yield. Next. So he tried whatever he could do. So first he tried all these things, 2.25. In fact, one of the 2.25 balloons burst. It didn't yield. Then again he tried another 2.5. By that time he had kind of tried close to 5 balloons. So the other colleague who was there in the lab said, "See, patient is stable. You leave it. We will see later." All these things. And by this time I had already reached home. So a typical response of mine was, since patient is stable, let us leave it. But somehow my colleague who was doing the procedure felt that I should come back and help him out. So obviously patient was on the table, so I drove back and tried to do a rescue for this situation. Next. So first thing I thought is, okay, let me increase the support. So I took a guide liner, tried to get a bigger balloon. So first started with a 2.5 non-compliant balloon, tried to enter. So if you see whatever you do with the guide liner, the balloon is the guide liner, despite increasing the support, in fact, the deep throating the guide, click on that video. Deep throating, nothing seems to, if you see the guide liner is right at the mouth of the stent. But despite that, despite, if you see in the second thing, the guide liner is right at the mouth of the stent. Despite that, I'm unable to get that 2.5 balloon inside. So the guide liner option didn't work out. It despite increasing the strength, I could not deliver the balloon distally. So somebody suggested to try OPN balloon. Next. So before that, again, when we are trying multiple, in fact, I must have tried some 5 different company balloons trying to cross, and all of them were actually smaller size, 2.25, 2.5 like that. The stent was actually 2.75. But one of the small balloons, I think it was AccuForce or something, it managed to enter, and it gave me some hope. Next, click on it. But despite the fact that it entered, it didn't create much of an impact, and I was like back to square one. So in this second part of the video, you see the balloon has crossed the lesion, but still when you pull back and try to inflate it, didn't give any result. Next. So we tried to, since that balloon had crossed, we tried another 2 point, that was I think 2.2. Next. Still not much results. Next. So still, practically speaking, there was no change in the thing, despite by now we had used around 10 balloons trying to open up this lesion. Next. So nothing is happening. So we're struggling, but now we are able to cross the balloon distally, but again, in my attempts also 2 balloons ruptured, but there was no result. Next. You see, every inflation, that portion remains more or less the same. Next. So this is all with guide liner inside the LAD, but still not much difference. Next. So this is my third big mistake. So we all know these special balloons are pretty expensive. So we should be very sparing in its use. But unfortunately, since I thought, let me cut on cost, so I directly took a 2.75 OPN balloon and tried to cross the lesion. So the trouble was, despite all the upsizing I had done with the 2.5 and 2.25 and all the things which I had done, this just go back, play that thing. So this is despite the fact that the balloon, I could not get significant purchase with that balloon, and despite multiple attempts at 48 atmosphere also, it could not open up. Next. So then I learned my lesson for the day, that whenever you are faced with this thing, it's always better to downsize. So I kind of took a 2.5 into 10 or 12, I think, and then that was the only OPN balloon which did the job for me. Next, click on the next. So that was the only thing that opened up the lesion. Subsequently, I retook that I think it was 2.75 OPN balloon, and then again dilated. Next slide. So finally, I could get the image, and then in fact I had the IVS image, but I don't have it now. But we could get a good result after post dilatation the second time. So after this thing, next slide. So finally, what seemed to be apparently a 5-minute PTCA ended up being 1.5 hours PTCA, including my travel time back to the hospital. then the final result was good. Next. Skip the slide. Next slide. So I learned we all tell postgraduates, we all tell others, but we many times in our hurry, like Praveen sir told, on a Saturday afternoon when we are in a hurry to go, many times we try to we don't estimate the severity of the disease because we do not do routine imaging. So I learned that in even in straightforward cases, if you have time and if you feel that it would be safer, it is always better to avoid direct sensing, and you should have you should use imaging whenever in doubt. In fact, when we used imaging, after we realized there was a kind of a spicule of calcium which was never visible in the angiographic images, and in the IVS we say, but that was too late. After the stent deployment, we realized that was the area where the stent had not expanded at all. So we should have an algorithm in mind as to how to deal with an undilatable lesion and how to deal with an undilatable stent. We all know undilatable lesion, going for rotablation is a very good alternative, but undilatable stent is a tricky situation because nobody would like to do a rotablation in an undilatable stent at the first presentation. So that is something we should have in mind. Next slide. Next slide. So this is the message that I learned, that OPN, despite its benefit in terms of going up in pressure, it has a higher profile. So the first thing that we should do is that if a normal non-compliant balloon is not working and we are trying to go with an OPN balloon, always undersize. So first get the thing done, and then later on you can post dilate with your routine non-compliant balloon also. And always, whenever your balloon gets stuck, one of the Japanese operator was telling that, as a routine, he sends even stent deployments also, he does like that: inflates, deflates, inflates, deflates, inflates, deflates. So we can always use it. And another thing is you should use it sparingly, because cost is a big constraint, and never reuse it because the profile is so difficult for you, unlike our other balloons, for us to reuse it. Thank you.
Thank you. Very good. I think, a wonderful case and lessons, well learned in this case. And the best thing I liked about your case is this new terminology: walk in the park angioplasty. So, but now you have to rename it walking up the hill angioplasty. Okay.
Yes, sir.
So I think it was good. Tips were good. But, of course, we have to remember that we have to have these armamentarium always, like open NC balloon has to be there in your lab every time. So don't let the inventory go away. Let it be there. And of course, now we will have Shockwave also. Even if somebody had Shockwave, one could have used Shockwave here as well, because it works very nicely. Of course, the cost is one of the biggest factors right now, but you can use that as an alternative. And earlier we were doing rota in these kind of cases, and that was ablating the stent inside these vessels also worked. So if somebody doesn't have a OPNNC, has a Shockwave, use a Shockwave. If somebody doesn't have a Shockwave also, doesn't have OPNNC, then what? If you have a rota, you can use rota also. However, if you have nothing of these, then what? Then the option is that you take a small balloon, like a 6 millimeter balloon, which should be slightly NC balloon, and we have now 6 millimeter balloon which are very focused in giving pressure. So you can take a 2.756, which will cross also. And the last thing I will add is taking a buddy wire in these cases many times helps to cross the lesion. So these are the steps. But let me tell you, you did a great job. Congratulations.
Thank you.
Okay.
Thank you.
This case was really
Yeah, Dr. Mandal, Dr. Mandal.
Sir, hi, sir. Good evening. Sir, a similar case I have also come across like this. That time, as you lastly said, that I have taken another buddy wire, and after that, I have taken a very small size of the balloon, only 1.5 millimeter. And the lesion was 2.5, and I was taken 1.5 millimeter with buddy wire. So that was worked very well. And I think these are the lesion is not needed pressure. if you do very high pressure open balloon, or that is, I think it is my opinion that pressure is not the important thing that we can open this lesion. I think the small size of the balloon and focused pressure is needed.
Yes.
As I comment.
So I can see, yeah, that's very good. So I can see Dr. Rakesh also. So Dr. Rakesh, you should also speak, tell your comments.
I have a comment.
Yes,
okay. In such case, I completely agree with you. The first step is to have very good support, because it's not easy to cross. The second step, it is to put a body wire, 1 or 2 wires. Sometimes I did one case like this. Retardation did not work because the diameter of the stenosis, the diameter of the coronary artery was very, very high. So I put 4 wires in the coronary artery, and then blast with the balloon. Because when you have a rupture of the balloon, you have a high pressure inside. But my advice today is to perform an IVL. IVL, if you can cross with this kind of device, it works very well. And we have such cases with bailout opening stents with the IVL. So IVL should be my first advice for this case.
Yeah, so for everybody's understanding, IVL is actually the same as shock therapy. It's intravascular lithotripsy. So if somebody must have missed out on that, so Shockwave.
I'm just going to take
just one comment.
Some of the questions that are coming from the audience. They're a very engaged audience. Dr. Anil Kumar is asking, any strength deformation did you notice? Could you have taken another wire to cross? And Dr. Santosh from KEM Hospital is asking, tell us how to use an OPN HP balloon sizing and techniques.
Okay. In fact, yes, sir.
Yeah, please go ahead, Dr. Hakim.
Actually, I tried the body wire. In fact, my colleague had tried that. In fact, I didn't show those images. In fact, before the guideliner, he had tried putting 3 wires, 1 in the circumflex, 1 in the 2 wires in the LAD. But somehow it did not help in crossing over. So we shifted to guideliner just to increase the support.
Okay.
And that is what couldn't help in this case.
Okay. So, any other questions?
Emergency to TriStar unit.
Dr. Manohar, you took 2.75 for, and went up to 48, but still did not open.
Yes, sir.
Dr. Apur, can you just mute your mic? Dr. Apur, mute your mic.
There was one question which came up about sizing of the OPN balloon. How do you use it and how do you size it?
Yeah, the standard, let me just tell you, the standard is for pre-dilatation, you should use 0.25 or 0.5 lesser, but for post-dilatation, you can do 1:1. So in this case, it could have been 1:1, which he did try to do that. But if it is not crossing or something, then you can take a 2.5 first and then switch over to a 2.75 NC, or you can go with another NC, another open NC. So those are the steps one can take. Of course, don't go beyond 1:1.
Yeah, just one point, when you use a body wire, it's difficult to then use an open NC, because then the lumen occupies more, the space is occupied by another wire, and it becomes very difficult to push the open NC with 2 wires inside the lumen. So in that situation, I think a wire like Grand Slam, along with good support and maybe your guideliner, would help, because using 2 wires with open NC is not really a compatible thing.
Yes, sir. In fact, the guide
compatible, but it as you pointed out that there are some difficulties at times.
It's difficult.
So what generally I recommend is, if you are using a BMW and you are repeatedly pushing balloons through that, the coating sometimes gets disturbed. Then you cannot push the open NC in that. Yeah. So then what you do is, the second wire which you put should be a Grand Slam or an All-Star. We use All-Star that in those situations, which is a non-coated wire, heavy duty, extra support, and you can then put the NC on this All-Star wire.
Yes, sir.
Let's move on to the next presentation. If we are running short on time, let's move on to the next presentation. We'll continue the talks. Dr. Ramesh Patel is the next presenter. He's going to talk about circumflex that taught us basics. And Dr. Patel is joining us from, he's an assistant professor at Gitanjali Hospital.
Thank you, Samir sir. Good morning to all. Good morning, sir. And today, all three cases were very beautiful and nicely presented by presenters. So, are you able to listen me?
Well, very well.
Yes.
So, coming to my case, sometimes what happen when we are trying things, when we are very casual, we may do some things which may land us in trouble, and this thing has happened to us at many times. Still, we are all of us are in learning stages, and some are at very high level, some are at still below level. So sometimes a few things are very simple, but still they will teach us basics. So my case is of a circumflex artery which has taught many things. So here there was a female who was 60 years, and she came to us with acute inferior wall MI, and it was late presentation, non-thrombolized, ejection fraction was 45%, and when we did angiography, circumflex was 100% was proximally occluded. Right coronary artery was 95% occluded in mid part. So let's see the angiography. You can some trouble is there. So anyway, the circumflex is occluded in the middle part, as you can proximal part. It is occluded in the proximal part, and we have it has been first of all, my colleague tried to open this artery. He wired the LED in the view of proximal occlusion of circumflex. Then he tried to open this artery, and when he was he used Sean black wire, and he went into a small branch. He tried to force open it. He was keep on rotating this wire, and when he was not getting any kind of good feeling on that wire. So what happened that the result was that there was a puff inside the circumflex, and he abandoned the procedure at this particular time. He thought that the patient is hemodynamically stable. He went into a small branch and has perforated it. He abandoned the procedure. Heparin was reversal of heparin was done. Now the thing came back again that what to do next, as patient was stable, there was no pericardial effusion. Next day I thought I was thing like let's try, I will try in this case, and I will do it in a proper way. I was a bit overconfident, and I did not place a wire in left entry descending. I crossed the lesion with the help of a Sean black wire. It was in a proper distal lumen of circumflex. Then I started dilating this lesion. Bit mistake of mine was that I was not keeping in opinion that thrombus can dislodge into left vein, and that happened in this case, where when I was trying to dilate the tight lesion in the proximal circumflex, the balloon developed melon seeding and popped up in left vein, and now the trouble began. Along with when the balloon came, it also brings some thrombus inside the left vein. Then as we were able to see that it migrated in LED, then further it migrated in distally into the circumflex, in LED, and then patient started developing hypotension. Now the crisis was beginning, and I was in trouble. So first I tried that I take out this wire from a circumflex and placed back into the LED, and tried to did thrombosuction from that LED, and was successful, and the LED flow was established. Now I again put my things toward a circumflex, and I placed a long stent in circumflex. Now I was afraid that I have come out from a situation where the patient went into a trouble. developed hypotension and almost got arrested. So I thought I have done a pretty good job. Did not done any kind of post dilation where even the melon seeding of a balloon was developed at this site. So I thought I've done pretty good job and I should stop here. The patient was stable. Flow was established in both of these arteries. I thought let's come out of this procedure. Now, after 2 months, this patient came back with chest pain. And when angiography was done, as was supposed that the result was this, the circumflex again was obstructed from proximally. So now what to do again? The patient has was having a bit pain, so not he was stable. She was stable, and we tried to open this artery. Now my third colleague has the patient come to my third colleague, and he attempted this case. Now, as he knew that this case has got troubled previously. He has developed perforation. He has developed thrombus dislodging into the left antedescending. He was now a bit in a situation that he has planned that he will do IVUS in this case. He crossed this lesion, pre-dilated, and then did IVUS. There was unexpanded stent in the proximal part of circumflex, and he did a pretty good job, dilated it properly, and ultimately the result was beautiful. So not take home message, because we all are at home. I have learned few things in this simple case, that while crossing lesion, we should have always those tactile feel and should not push hard inside the lesion. Sometimes we may go get into some small branches that can perforate them. And when we are treating osteoproximal lesions, our teachers and our seniors always used to teach us, always protect the main artery, which is disease-free. So protect other artery by keeping wire in it. If there is some kind of emergency, you will not waste your time while switching the wire or putting another wire. And sometimes thrombus can be handy at times. Proper post dilation can reduce chances of instant restenosis, and obviously imaging and other imaging modalities have usually improved the results. Thank you.
It was very, very nicely done. Of course, and the follow-up was equally well done. So I must congratulate Dr. Patel. I think you are from Udaipur.
Yes, sir.
Yeah. So I know that you people do a very good job, and so well done, I think. And of course, the learning has been great in this case. And let's have some comments from our panelists. And I can see the names here that Dr. Prashant Jagtap and Dr. Amar Singhal, Dr. Apur Vaswada. So please, make some comments or some suggestions for Dr. Patel's case.
Only one question. Thank you for this very interesting case. But what was the antiplatelet regimen for this patient for this procedure?
Sir, initially this patient received aspirin and clopidogrel. Later on, we switched to this ticagrelor and aspirin.
Okay. Just one comment that I have is, whenever you have a patient who has had a recent MI and not thrombolized, this patient was not thrombolized, right?
Yes, sir.
There is a chance that there is a lot of thrombus burden. So whenever you have a patient who is not thrombolized, there is always a chance of having a lot of thrombus burden, and then a chance of dislodging the thrombus like this. You have managed the case very well. That was one point which I wanted to make. And the second point is, obviously your long stent in the circumflex was ill deployed.
Yes,
just due to a long stent, you didn't post dilate. I would probably when the stents are so long, I would probably do not worry much, but go ahead and post dilate these stents very properly at the end of the. I agree that you had a thrombus, so you were worried, you were afraid that you might produce it, bring this thrombus back with your balloon into the left main. But what happens is, when you have a problem once, the next time your level of your worry goes up exponentially. So I think I would have post dilated this long
Yes, sir. There were a series of mistakes which were done on our side. I think not keeping a wire in LED, then not post dilating. So there were a series of mistakes. So all these were learning points for us, and probably we are not going to repeat it again.
Dr. Ramesh,
yes, sir.
can you tell us what exactly was the finding of the IVUS in this case? Because that will give us a clear idea of three things. One, whether it was clearly stent, under deployed stent. Number two, whether it was restenosis. And number three, whether it was just thrombus when the patient came after 2 months. And that will give us good insight as to what could have been done better. So can you share the findings of the IVUS?
Sir, I'm sorry that I was images I was unable to produce here on the presentation.
No, whatever you found, you just.
But what we found that it was under expanded stent in the portion of the there was under expanded stent where there was tight lesion. So otherwise it was well expanded in other portion of the lesion. Probably it was the reason of developing stent thrombus, which we thought. And when we dilated it with the NC balloon, the result were better.
Dr. Samir, can I give a comment?
Yes, please, Dr. Singh. Please go ahead.
You know, this scenario of thrombus migrating from one artery to the other is very, very kind of devastating. When you're addressing one lesion, you end up with another one. So what I typically do in primary angioplasties is, after the balloon dilatation has been done and the balloon has been withdrawn, I open the Tuhi boost and see for the backflow of the guide. Sometimes this thrombus has not gone into the other artery, but it is still in the guide catheter. So if the backflow is unobstructed, then it is fine. Otherwise, I just forcibly withdraw 5 ml of blood and throw it, and then you take it. Because if you don't do this, any thrombus which is sitting in the guide catheter, with the next injection, it can go to the other artery. So this is kind of a preventive measure which I take in PAMIs. It is proved quite useful.
Yeah, that's a very good comment. In fact, this could also happen that once you are doing a procedure for long duration, even thrombus can form in the guiding catheter. You are doing multiple, exchanges. That guiding catheter, that clot can get pushed. So keep checking PCT and keep checking whether the guide catheter is clean or not. I think this is a
very important point. You know, when not only during dilatation, but whenever you are doing thrombosuction, when you withdraw the catheter, let the backflow of the blood go on, like at least 5-10 cc's, let it go back, without any problem. Even in a thrombosuction catheter, part of your thrombus can remain behind in the guide catheter when you are removing the thrombosuction catheter, and then during next injection it can go in.
Dr. Vaswara has a comment.
Yeah, this is regarding both the cases, the previous one and this, that we discussed in the last case that hazy looking lesion which did not dilate after the stent, after direct stenting. If you don't have imaging, you can use a poor man's IVUS. You put a balloon there, do a stent boost in 2 angles, and most of the time you will be able to judge whether this requires a preparation or not. So you did not have an imaging every time, because most of the people, the expense, the timing is an issue. And so we call it poor man's IVUS. It's very useful.
So I think, quite a lot of discussion already done on this case. We have to keep moving. It's already 11:20. And so Samir, can you just proceed?
Yeah. So the next case is going to be of a stuck balloon by Dr. Madhu Sridharan. And Dr. Sridharan is joining us from, he's the Director and Chief Interventional Cardiologist at NIMS Heart Foundation in Tiruvananthapuram.
Samir, I'm afraid I have to leave between for an emergency. So, thank you very much for all, and I must apologize for living in between.
Thank you so much for your comments, Dr. Chandra. It was great you were able to share your wisdom with us. Thank you.
Yes. Can you see me and hear me?
Yes.
Okay. Now, this is a case of a stuck balloon. This patient is a 58-year-old man who had presented with an acute lateral wall MI, presented more than 18 hours. He had an angioplasty to LAD a few years ago. ECG showed QS and inferior leads, and echo showed RWMA involving the apex and lateral wall. Now, this is the angiogram. You can see a tight lesion in the OM, which is a culprit lesion, and this is the place where he had a stent before. It is a fairly simple lesion, and he had a direct stent to OM with a 3/18 signs. So as of all routine procedures, especially when it's direct stent, we post-dilate, and this is post-dilated with a 3.5 to 12 non-compliant balloon at high pressures. and then starts a problem. The post-dilatation balloon is not deflating. So what are the options that we have in case of a stuck balloon? You can either aspirate with a new device, you can deep throat the guide till the balloon and try and deflate the balloon with the guide acting as a thing to kind of deflate the balloon. You can use normal saline to inflate it further and get out the contrast. You can hyperinflate the balloon and try and rupture. You can deep throat the guide and pull back, which I said before, or use a stiff wire to try and perforate the balloon. And finally, this is what we've done in a couple of cases before. You pull hard on the shaft and the shaft breaks. So when the shaft breaks, the balloon deflates, and this can be brought back out of the body with another balloon, which anchors the remnant of the shaft against the guide. So you take another balloon all the way till the tip of the guide, inflate the balloon, and that anchors whatever is remnant of the balloon within the shaft, and you pull out the whole thing together. So these are the things that we have in case of a stuck balloon. So we tried doing one after another. We first aspirated with multiple devices, high pressures, it was not deflating. Deep throated the guide, it is an EPU, it went all the way till the end of the balloon, and we are pulling the balloon against the guide, but it's still not deflating. So now we try to perforate the balloon with another guide, put another guide to the left femoral, and this is a Conquest Pro 12, which is being tried to use to perforate the balloon. It's not successful. Inflated to high pressures, the inflation device could go up to 30, it's gone up to 30, but it's still not rupturing the balloon. So we thought we would do the last thing that we have. We tried pulling the balloon hard so that we intentionally kind of breaks the shaft. So when the balloon breaks and part of the shaft remains inside, the balloon would normally deflate, and then you can take it out. But unfortunately, in this case, we pulled the balloon ruptured, but it is still not deflating. So then we were in a fix. We thought we would get a snare up to hold the shaft, but the snare would not go up, probably because the remnant of the balloon was within the guide, and this was obstructing the snare going up. But subsequently, even the balloon would not go up the guide. So the guide was withdrawn, but as it had no other purpose because we couldn't get anything up the guide. And now the blood pressure was falling. There was changes in the ECG, and the patient was complaining of chest pain, and the surgeon was on the way. Now we did a cine to see if there's anything hanging out, and we could find that there was this shaft of the broken balloon, which could see this is the arrow, which is a very faint thing, but you could see something hanging around here. So thought of snaring it with a N triple loop snare. There's a snare, and this is the wire. We thought if we could snare it and pull hard enough, if the balloon comes out, then we could save a catastrophe. And this is what we did. It was snared, and we took the snare all the way up so that we could get more pulling pressure. And on pulling, fortunately, the balloon came off. After that, the patient, the stent was dilated with the post-dilatation with a higher balloon at higher pressures, and this is the final result. And these are the two parts of the balloon that we could find. This is after rupturing. This part stayed within the guide, and you could see the end of the balloon with the remnant, which is all distorted because of the snare which you're trying to push up. And this was the part which had come out when we pulled the balloon, and this is remaining within the guide. So there's damage to the lower end while trying to take at the snare. And this is the balloon, which is remaining inflated even after coming out. So it was acting as a stuck valve, was a one-way mechanism by which whatever was inside was not getting deflated. So in this case, we used all the possible methods that we could have for a stuck balloon. We pulled against the deep-throated guide, then deflate, hyperinflation of the balloon, try and rupturing it without luck, perforation using a stiff wire on the opposite side, couldn't perforate, broke the shaft by pulling, but still the balloon did not deflate. And finally, it pulling at the balloon shaft remnant, which is snared, finally work, pulling out the whole balloon, but it is still undeflated. So no angioplasty is simple until it is finished. You have to keep improvising in case of complications. Most complications can and should be sorted out in the cath lab because you probably would not get time otherwise. But always keep your surgical colleagues in good humor. You never know when their help would be needed. Thank you.
That's a great case, Dr. Sridharan. You're right. There are no simple cases. There are only simple people.
Very interesting case. Very interesting. I have a comment about that. The explanation of this first. The explanation is that the body of the balloon is stretched. So the lumen of the balloon is small. So you can inflate the balloon, but you cannot deflate because you have a suction inside the. That is the explanation. What can be done to break the balloon? You can cut the body of your balloon, and then put a 5 French guiding catheter, which can be cutted. If you cut the tip of your 5 French catheter, guiding catheter, you will find inside some metal, and you will have like a knife, you know. The tip of your guiding catheter will be like a knife. Then you put it inside your 6 French guiding catheter through the body of the balloon, then go to the balloon and turn your guiding catheter inside. You will break completely your balloon. In my experience, it is the best way to break a balloon. The wire is not a good choice. To pull it back, it's not a good choice. This is a very interesting tool. Of course, we don't use it every day, but it is a good solution. And how to prevent that? Because when we use non-compliant balloon, especially when we perform proximal optimization technique with big balloons, non-compliant balloons, so we have to check outside the patient if the balloon get down easily before performing the last pot technique. So that's what are my comments.
That's an excellent one. Just a question regarding the 5 French. So do you cut the tip of the balloon which is outside before you put the balloon?
Yeah. You cut the balloon outside, and then you cut the tip of your 5 French guiding catheter to have like a knife, and then very gently you get inside the artery, and you will go to the balloon and break it easily with your knife.
Okay. Oh, that's great.
Yeah, Dr. Madhu, one small comment, like in your attempt that you actually pull the shaft of the balloon very forcibly, trying to break it somewhere. But if you actually were trying to do that, why did you not consider breaking the shaft outside, whatever the shaft is visible in front of you? Why did you not cut it there in a way to try and deflate instead of breaking it somewhere uncontrolled inside the body? Breaking it outside would have been possibly simpler, and still you would have had some portion of the shaft with you to do pulling and pushing if required, instead of trying to trap it later on.
Okay, that's fine. Because normally we've had a few cases when we pull it, and what it normally breaks is at the hypertube. So quite a part of it will remain outside, and that part is anchored with the balloon, and we pull it out.
Yeah, but that's still a very, very difficult maneuver to again in a difficult situation. So I thought maybe if you really wanted to break, why not break it in a place where it's visible and you still have something to hold on to?
Fair enough.
Very interesting.
Comment is that mostly what we propose this type of problem once also. That time it was because of the dilution of the dye contrast. There is another important factor you have to keep in mind, that contrast material, which is normally weak of 3:4:6, like 10 ml of if you can 1:4. 10 ml of dye and 40 ml of contrast.
If it's contrasted, if the concentration is more, it will not come out.
Concentration with the, if it is a higher concentration, that is the chances of getting stuck it's more frequently, and at the same time the reusability of the balloons. There is another important point.
Yeah, just one point I would like to make, that these non-compliant balloons are difficult to puncture because their material is a little thicker. That is one. Number two, as somebody said, why can't we rupture the balloon or shaft in an accessible part? The problem is, if your obstruction, the valve mechanism is at the junction of the catheter and the balloon, there is no point in cutting it or releasing the obstruction in the proximal part, because it will never work. And the third important point is, which I had read somewhere, that this hard end of the guide wire, you can try and puncture it with the hard end, but it's very difficult to negotiate the hard end of the wire up to the balloon. So in that case, what you can do is you take out your guide out, you just pull out the guide, and then try to put another guide through the other leg, and try to the point is, whenever you had already pulled your balloon out and there was a thin shaft remaining, right, at some point.
Yeah.
So in that situation, you can put another guide from the other end, other leg, and try to put in a guide liner through it and take it near the balloon and try to puncture it.
Now, Dr. Bhagwat, here we had taken the guide all the way down to the balloon. It was not deflating, so the guide liner wouldn't help.
Oh, so
the whole guide was taken.
I missed it. Right. So did you try hard end of the wire at that time?
No, we tried with the hard end, but the problem with the hard end is when you put the hard end, we are pushing from the soft end, so you don't get enough pressure. So from the other side, we took a Conquest Pro, and even that could not perforate.
Yeah.
Oh, okay.
Dr. Macaulay has a quick comment.
2 points. One is I have encountered these type of problems on a couple of occasions, particularly when we're reusing the indeflators, where with them sterilizing them in the Cydex solution. So a small crystal which remains there inside, and this acts as a check valve at the end, and it doesn't allow to deflate. Or even a small particulate matter which acts as a check valve at the final end of the balloon inflation. Point number 2, about perforating the balloon from the proximal. What I have done on one occasion, that I parked the wire, I took another soft wire, parked it by the side, put a microcatheter over it, and through the microcatheter, I went directly with the hard end of the wire and perforated. So that also means, rather than putting another guide catheter, etc., you can do it through the same way. But in this particular situation, in your case, the balloon did not deflate even it came out.
Yeah.
So that means there was something which is happening as a check valve at the end of the balloon, where the final, the tubing which goes into the balloon. And I personally feel there was small crystal. Possibly if you would have opened that balloon, you would have got that particular small crystal out. It can be even, for that matter, a small glass piece also.
I think we're just going to hold that thought. That's a great presentation, Dr. Sridhar, and I think we'll have to move. We have 25 minutes and 4 more cases. Our next case is going to be from Dr. Shrikant Yeram, who's going to talk to us about how we got into hot water and left, how we got into hot water during left main PCI. And yes.
Yeah. Hello.
Yes.
Good morning, everybody. Today I'm going to show a case. I think it was not simple by any means, but I'll just show you how we got into trouble. And they say when it rains, it pours, and one issue led to the other. And but finally we ended well. So whatever ends well is fine. So this was a 53-year-old man. He was hypertensive. He presented with unstable angina. He had normal function, and these are the guide shots. I mean, like these are the angiograms. Basically, you can see there's a tight distal LM lesion with tight ostial L6 lesion and probably significant LAD ostial lesion as well. So his syntax was borderline. So we discussed about CABG and PCI in him. And finally, we went ahead with PCI. From the beginning, we knew the strategy. So we wanted it to be elective double stenting, and we chose DK crush as the strategy. This is something which we are comfortable with. We used to struggle with classic crush, and once we started doing DK crush, and we have less problems with DK crush when compared to a classical crush. We could have chosen the culotte as well from LM to L6, and then do a culotte to LAD. So that would have been fine, but somehow we chose DK crush in this patient. So LCX was pre-dilated and we did a OCT run. It's a shame I could not show the OCT images today because of technical reason, but I would allow to show them. There was calcium, a mild calcium in the austral LAD and minimal calcium in the distal LAD landing zone. LM was measured to be 5 mm, LAD was 3.5 and L6 was 3.5. So we pre-dilated the LCX and then with a 312 balloon, and then this was the stent in the austral LCX. You can see there the LAD balloon is positioned across it to crush it. So this was the stent being deployed. This was the initial recrossing. So what actually happened? This is the first recross. You can see there the first recross into the LCX, and then we dilated the strut with a small balloon. Everything was fine until then. So then this happened. So then patient started having hypotension, and then he developed angina. And you can see there the LCX stent is okay, reasonably expanded. But if you can look clearly, so where we have landed the LCX stent. So this is after the first crush. I mean, we could crush the LCX stent here. But we, in the process, what actually happened in landing a piece, after crushing the LCX stent, we tried to take a balloon into the LAD. We could not pass any devices into the LAD. And in trying to push the devices into the LAD, we lost the LAD wire because nothing was passing into the LAD. Then, I mean, we realized the issues later after that. So we knew what had happened. Then after this, once he started having angina, we used a workhorse wire, which is our run through. We could not cross into the LAD. We used another wire, but finally we could cross after multiple attempts with a fielder FC into the LAD. Once we had access to the LAD, then so we understood what has happened. So basically we used a small balloon, and then again we crushed the LCX stent, and then we did a first kiss. You can see there, this is the first kiss. Then after looking at the first kiss, we understood where the L6 ostium was, where the L6 stent landed. So, and how we crushed the L6 stent. So finally, this was the first kiss, then we stented the LAD. So as fast as could. From this point onwards, we started working fast. If you remember, if you see the angiography here, so retrospectively, the patient was a little sick, so we were in a hurry. So we chose a 3.5 to 30 mm stent in the LAD. So this was the stent which was being positioned. You can see the proximal landing zone. We thought this would cover, but retrospectively, we were proved wrong. So this stent landed here in the LAD, and we did a part. We thought after the first angio it was good. We did a part with a 5 mm balloon, and then we did a second case, and this is what we landed up with. You can see there, this is dissection, distal edge dissection in the LM, and then what probably would have caused here the difficulty was the size of the kissing balloons. We did not downsize by 0.25 with the kissing balloons, and the positioning of the part balloon. So part balloon, we were not sure whether we had positioned it exactly near this thing, or it would have protruded a little proximally, and did we miss a dissection in the initial angiographic run? So, or we did not take it seriously, where we were positioning the stent proximally. Then we took another stent in the LM, so this was positioned to cover the dissection, and then we did a final part, and this was the final angiographic result. You can see there, there was good opposition, good stent expansion everywhere. This was the final OCT run. Sorry, I don't have the OCT images, but everything was fine in the end. This was a check CAG. We wanted to see how it behaved in the with the check CAG, and after a few days, and everything was perfect. Patient is asymptomatic and he's on follow-up, he's doing fine. So what actually went wrong? So we actually started protruding the stent as little as possible. This is what we do regularly. We protrude the stent as little as possible into the main vessel, the side branch stent. But here, the problem here was our estimation of the L6 ostium was not appropriate. So we did not understand the bifurcation anatomy probably. So a lot of the stent protruded into the main vessel, and we did not adequately crush the stent. So losing a wire access to the main vessel after inadequate crush will always land us in problems. That's what we had. We could not push any devices into the main vessel after that. with difficulty, we wide the main vessel, and then we crush the side breast stent adequately with adequate pressure, and we could get access to the main vessel. Again, because we had dissection in the main vessel, we had very limited time for doing all those steps. Coming to the kissing balloons, so probably the first rule is what we use. Usually we downsize by 0.25 to match the main vessel diameter, and we choose the kissing balloons. Probably we did not do that here. That's why we ended with edge dissection in the proximal main vessel as well. So what we learned from this, so mainly to understand the bifurcation anatomy, profile the bifurcation properly in multiple views. Here we could have used more alevocardal to show the L6 ostium properly. And when you're doing the first case, or when you're doing the crush, try to understand where your stent has landed. And then most important thing is to protrude the side vessel stent as much as possible. Always attempt for a nano crush or a micro or a nano crush, and adequately crush the stent with a good sized balloon. So see that you crush it properly, and don't lose access to the main vessel once you crush the stent. So this is very important, because if a lot of stent is protruding into the main vessel, we may have difficulty recrossing into the main vessel. And then if devices don't track, understand the reason, try to troubleshoot rather than using force, because you may end up losing the whole system there. And always, we should always look at angiographic pictures intently. So we knew that there was some dissection in the LID. So I mean, like we could have been more careful while pushing the devices if there was an angiographic dissection. And if you had looked intently at the proximal LM dissection as well, we could have probably landed the stent little proximally more, covering the dissection completely. And always assess the characteristics of the landing zone. Even the LAD OCT was showing mild calcium in the landing zone. Wherever there is calcium, so there is a high probability for dissection. So that's also important. Appropriately size your kissing balloons, and appropriately size and position your pod balloons. I think these are very important to avoid edge dissections as well as good result. I think that's what we learned from this case. Every case teaches us. I think these are some basic things, and which we do them properly, probably won't land these problems. Thank
Just
you.
one question: what size of the balloon was used to crush the circumflex stent?
It was a 3.5 3 mm balloon.
It was 3 mm, 3 mm compliant, non-compliant?
NC balloon. It was NC balloon. So
NC
here
balloon.
we did not use any compliant balloons here. All the balloons which were used were non-compliant balloons. We could have used a compliant balloon for pot, but we used a NC for all the.
And I'm not sure whether you pulled out the circumflex wire before crushing. Did you pull out?
Yeah. We do it. I mean, as a routine, we pull out the wire and from the L6 stent before crushing. I did not show all the steps for brevity.
No, that's okay. I just wanted to confirm. So you crushed it with 3 millimeters balloon, right?
Yes, sir.
So in retrospect, what do you think? You should have crushed it with 3.5?
Probably we could have crushed with the 3.5 mm balloon, and we could have used a little longer, and we could have gone to a little higher pressure as well with the 3. These two, I think, adequate sizing of the balloon to crush and adequate pressure, probably where we went wrong.
I think your point is very well taken. The point at which you can end up getting into problem is inadequate crushing into the main vessel. If your side branch stent is not crushed adequately in the main vessel, your entire procedure can go haywire. So it's sometimes very difficult to make out whether you have crushed it properly or not, only by looking at an angiogram, or just by it's just important to use the proper size of the stent. You just go as much. Sometimes I have seen that we encountered this in, say, LAD diagonal, even bifurcations. In that situation, we have gone up to we have upgraded the size up, and sometimes produced dissections in the main vessel in order to crush the side branch stent. So your point is well taken. The crushing that stent is a very, very important step.
I'm sorry to be the party pooper over here, but we have only 15 minutes and we have 3 more presentations. So we'll just go for presentations, and then we'll take comments in the end, if that's okay with everyone. We're running really short on time. Dr. Rakesh Rai Sapra is going to be presenting the next case, unexpected complication in simple angioplasty. And Dr. Sapra is joining us. He's the Director of Cardiology at QRG Health City in Faridabad.
Can you please unshare your screen so that I can share mine?
Right.
Thanks. So before actually I start, I would like to add a small comment on the last case. One small technique that you should always do, which actually helps a lot in confirming whether your stent has been crushed well, whether the struts have opened well, because at every step in bifurcation angioplasty, it's not possible to do IVUS. So at every step you can do stent boost. So when your balloon is there, if you can do a stent boost before you pull out your balloon, you actually can see how well your stent is crushed, how well your side branch strut is open. So that actually becomes a very, very easy tool to incorporate.
Sorry, can I have a word?
Yeah, sure.
Here actually one more issue in addition to crushing was the more protrusion of the stent. So whenever the side branch to the main vessel, we tend to have these problems more. I mean, identifying the side branch ostium was also more important actually because of the LAD origin. So we had those issues.
Thanks. So let's start with this next case. I think we have seen quite a few dragons today. So let's go ahead and see this invisible dragon in my case. This was a patient, 65-year-old gentleman who came to me with non-ST and tier myocardial infarction. And on angiogram, we found he had double vessel disease. There was a thrombotic lesion in mid-LAD and a stable focal lesion in mid to distal RCA. So we went ahead and treated the culprit LAD lesion first, but the usual balloon and stent. And we got a decent, adequate result with good TIMI3 flow. And so we decided to go ahead and treat the non-culprit, a simple focal lesion in RCA. And we pre-dilated the RCA lesion with a 2O balloon. And this run shows the image after pre-dilatation. The lesion had opened well and everything looked all right. So we decided to go ahead and put in the stent. So we took a 16mm stent there. But at that point of time, when I did the check shoot, we found that invisible dragon. And the dragon here was that when I did the check shoot, the RCA was found to be completely occluded at the ostium. And we found a dissection flap in the aorta. So, I mean, unfortunately, I cannot show that fluoro because we could not save it. But this is, you can see a reconstructed image which I have created to show that post-ostial occlusion in RCA. And I put few dots along the line to show the dissection flap in the ascending aorta. And there's a small flap in the coronary sinus, but there was a more flap seen in the ascending aorta. And in fact, in this fluoro run, you can see the same flap a little more faintly where we have not injected any more dye. So this was the problem. Then the issue, fortunately, one important luck was that the patient was hemodynamically stable and was not complaining of chest pain. So I had some 1 or 2 minutes time to react. But the moment I saw this ostial occlusion, the treatment plan was very clear that I had to stent the ostium. But my stent for focal lesion of RCA was already there. And I did not have any further dye guidance. But because the location of lesion was in a way simple, it was at the bend. And I knew that it was a focal lesion just after the bend. And my stent was there. So I decided to put the stent there, implant the stent there, and then quickly come back and take another appropriate side, little bigger stent and stent the ostium. Again, while covering the stenting the ostium of RCA, I could use that dissection flap as my landmark to decide the proximal extent of the stent without actually using any further dye. Well, I mean, I had considered pulling the first stent proximally and stenting the ostium first to get the flow into the RCA quickly, but it was inadequate size stent. It was smaller stent, 2.5 versus 3, which I wanted to use at the ostium. And fortunately, patient gave me that extra minute to do this maneuver of getting another stent and stent the ostium. But moment I stented the ostium, the problem actually was solved. And what we found was a good opening of RCA. The flow in RCA was absolutely normal. In fact, fortunately, by stenting the ostium, most likely I covered the entry point of the dissection. So the flow in the upward dissection in the ascending aorta stopped. And only a small flow in the dissection in the coronary sinus was what remained. And patient remained stable. We observed for a while inside the cath lab. Patient remained stable. There was no chest pain. There was no hemodynamic instability. We shifted the patient to CCU. We monitored patient with serial echoes, watching for development of aortic regurgitation or any new pericardial effusion. But fortunately, none of that happened, and patient was discharged comfortably 2 days later. So the take-home message from this case, I would say again, is that no case can be or should be considered simple. The reason for dissection in my case was possibly non-coaxial guide location, which you can see here, that and a mild plaque at the ostium of RCA. So my guide was not completely sitting inside the RCA, and there was a small plaque at the ostium, which possibly was the site of dissection. Possible prevention in such a case can be, you should try and keep non-coaxial guides a little away from the ostium, which can help in preventing such complication. And obviously, early recognition and quick action in some such complication can save your day. And that the small residual aortic dissections, which I left in the coronary sinus, heal, especially if the entry point is sealed well by the stenting. Looking at a small review of the literature of iatrogenic aortic aortocoronary dissection, what I found was that this is a very, very rare complication during PCI with an overall incidence of 0.02%. And for unexplained reason, this has been found to happen more often if you're doing angioplasty in acute MI setting as compared to non-acute MI setting, 0.19% versus 0.01%. Denning et al. Has classified this complication based on the extent of dissection. Class 1 being dissection only involving the coronary cusp. Class 2 extending up the aortic wall, but to less than 40 millimeters. And class 3 when it is extending more than 40 millimeters. This classification is useful for risk stratification because obviously the extent of dissection, if it is class 3 or if there's evidence of ischemia in any aortic branch or hemodynamic stability, it would mandate urgent surgical intervention. Thank you very much.
That's a great presentation. Thank you so much, Dr. Rakesh. Unfortunately, we will take questions in the end because we are running really short on time. I apologize for that. Our next presentation is by Dr. Gaurav Verma on complications makes us all learn. Dr. Verma is joining us. He is the head of Department of Cardiology at SBMT Hospital, Ghoti Nashik, Tambe Hospital, Sangamanar.
Hello. Good morning, everybody. I'm audible there?
Yeah, absolutely.
Yeah, first of all, greeting from Nasik. And I'm presenting a case which got complicated. It was simple to start with. As we are watching very nice and exciting cases in the since morning, and we are finding complications which are happening even in the simpler cases. And we all know that complications are inevitable. They are bound to happen. But the best is to know how to treat them. Whenever the complication happens, we should be geared up to see that what has happened and how we can tackle them efficiently. My case was a nightmare. He was a young patient who was non-hypertensive, non-diabetic, had angina of 2-day duration, and ECG showed evolved inferior wall MI with at presently symptomatic for effort angina. Echo was showing mild inferior and posterior wall hypokinesia VE for 45%. Angio showed a small discrete short segment lesion in the proximal circ. It was a type A lesion, and anybody can guess that it's a 5-minute job for a routine as a routine angioplasty. Routinely radial route was taken, 5,000 heparin was given, EBU guide was taken, and floppy wire used to cross the lesion. And as usual, it was dilated with a 2x12 balloon. But immediately after balloon dilatation, we could see some thrombus in the proximal part of the circ as well as at the lesion site. So we thought that there is a because of the milieu, the patient is having a acute MI. It may be that patient is having thrombus. So we thought that we'll do the things fast. But as soon as we was thinking about it, the patient has ST elevation and severe chest pain. We could find that the lesion has closed down. Still, we were thinking that it's quite manageable. We'll take a stent and just put it. As we were thinking, the next shoot showed that. So we just thought that we'll dilate it again to have a flow. But as we dilated it, we found that there was some thrombus in the proximal segment as well as in the distal left main. So we thought that as the thrombus is extending, so we'll change the guiding. There is a simply a case of that we are having a thrombus in the guiding, so we should change a guide, and we should try with a new guide and new wire. But we took a wire, we let the wire there at the position, and we thought we'll change a guiding. As you can see, the thrombus is there. So as we were thinking of changing the guide, immediately the patient crashed, and patient has an arrest. Immediately CPR was started, inotrop were began. We checked the ACT was 204, and heparin was given, and intracoronary tirofiban was also given. So we then took a the stick from the right femoral, we cannulated it, and this is what we found. Patient was in hemodynamic collapse, CPR was going on, and immediately we put on a thrombus aspiration catheter, export catheter, and we're aspirating the thrombus. What looked simple, a 5-minute job, as you know, turned out to be a nightmare, and we were just praying to have the patient live, because you can imagine what was the situation. There was panic everywhere in the cath lab. Anesthesia people were intubating the patient, CPR was going on, DC was there, multiple runs of VP were just occurring. So we continued with the thrombus aspiration, and this is what gradually we were having. We were having some activity in the heart, some flow was there, but still we are not having the thing what we wanted. We continued with the same thing, inotrop, CPR, and thrombus aspiration. Finally, we could find something good, that LED flow started to LED started to flow. Immediately we wired the circ in another guide wire. As circ thrombus was aspirated with the export, and we could find that some activity has started to come. You can find that we can see that activity has started, heart has started moving, but still CPR patient was going to asystole, and CPR was required. Finally, with the high dose of inotrops, we could find a good activity. BP started coming up, and thrombus in the LED was thrombus in the LED could be, we could see that it has washed away, and flow was started in LED. Finally, immediately we stented the circumflex with a 3.5 stent, and finally we could achieve. And as everybody told that whatever ends well is good, so we could find a good result. And after 3 days, patient could be shifted out to ICU, and we could manage to discharge after 5 days. So when we review that, it was nothing like we were short of anticoagulation, but during intra-procedure definitely ACT was low, but then we thought of that it may be that antiplatelet therapy was not that effective, because the patient was on clopidogrel. So I want the comment of the all the panelists, that whether we should be always go ahead with this Brilinta or Prax, and should abandon clopidogrel at the moment, or there is something other which we can think of. And I want the view of all the panelists in this.
That's a great presentation, Dr. Verma. Unfortunately, we will not be able to take much in terms of comments. We have already finished time, and we have two more presenters. So, are we done, Dr. Verma?
Yeah, I'm done.
Okay, yeah. So that was a great presentation. I think it's a great save. A lot of learning over there, but unfortunately, we do not have time for comments. Our next presenter is going to be Dr. Narasimha Pai, who's going to be talking to us about missing the invisible dragon. Dr. Pai is joining us from, he's Associate Professor, Department of Cardiology at KMC Hospital in Mangalore. Dr. Pai.
Next for the last 2 days and rest pain for 3 hours. Shantanu. Hello, am I audible?
Yes, doctor, you're audible now, Dr. Pai.
Yeah. Shantanu, can you please change the slide for me? Can you go to the next slide? Hello.
Yes, Dr. Nasima, is this the slide you need?
Yeah, go to the next slide, please.
After the ECG, the echo?
No, go to the second slide. Yeah, I'm still seeing only the first one there. Hello. Okay, so her vitals were stable, 150 by 90. Her pulse rate was normal and her examination was normal. So can you share the ECG, which showed a hyperacute inferior wall MI with ST segments up in 3 and AVF and ST sagging in 1 AVL V2 to V6. So we went ahead with the echo, which showed hypokinesia of the inferior and infraseptal segments, a non-dilated left ventricle, very trivial MR.
We are not able to see the slides, Dr. Pai.
Yeah, I think Shantan, I'm not able to share the slides from my.
Click on enable editing. Click on enable editing.
Hold on, Babu. Slide share kar jayena. Patient had received the dual antiplatelet therapy from the local general practitioner and statin. And unfortunately,
to enable editing or somebody who is on control panel, enable editing, that you just click on that button. You have to click on the button of enable editing, the top line of the your presentation.
So is this
presentation? You don't need to edit.
On the top.
No, you don't need to edit. Just keep playing. No, Shantanu, you can just keep playing the slides.
So is the slide visible to everyone?
Yes,
yeah.
Slide is visible.
Only the first slide is seen. Go down, please. Shantanu.
Yes, sir. Is the
slide shows?
Go to slideshow.
Yes, go to slideshow first.
Just a second, I'm putting it back.
Yes, that's perfect. You go to slide number 3 there. You go to slideshow. Shantanu, go to slideshow. Yeah, perfect. Yeah, I think this is visible. You will have to change the slides as I tell you, Shantanu. The ST segment up in 2, 3, I think that's visible, and ST sagging in 1 AVL and V2 to V6. Yeah, go to the next slide, Shantanu. Echo showed regional wall in the RCA territory, non-dilated left ventricle, very trivial MR, and good ejection fraction. Patient had already received ticagrelor and aspirin from his treating general practitioner outside, along with statin and a dose of unfractionated heparin before he was moved to our hospital. So can you run the angiogram for us? His left system, Shantanu.
I'm running the angio.
No, it's not visible.
Not visible.
Don't run that.
You have to select that slide first.
You have to go to the slide first. See, go to the slideshow.
Sir, it's on slideshow on mine.
Yeah, play that.
That is
I think play that. Just click on that. Perfect. So you can see a mid circumflex showing a 50 to 60% stenosis. Go to the next slide. The LAD also showing a borderline lesion. Go to the next slide, Shantanu.
Click on the slide. Yes.
Yeah, click on the slide. Yeah, perfect. Play that. Yeah, you can see a borderline lesion in the proximal LAD. Go to the next slide. And yeah, play that. Yeah, perfect. So the left system looked fairly all right, except for mild plaquing in the mid circ and proximal LAD. And the right coronary artery, play the RCA there. Go to the next slide. Yeah, play the RCA. It looked like a very short, discrete mid RCA type A lesion, which we would have finished the angioplasty probably in a matter of 5 to 10 minutes. Okay, so after explaining the risk, we went ahead with the radial angioplasty. You can play the next slide. Yeah, play that. This is the angiogram picture. And go to the next slide. So we decided to go ahead with the transradial angioplasty. We took a JR 3.5 guiding catheter, a workhorse BMW wire, and we thought that we will predilate this lesion with a 210 sapphire balloon. We did that, and the moment we pulled the balloon back, the patient started complaining of chest pain, blood pressure started falling, patient developed bradycardia and was restless. We just gave atropine and started inotropic support, but then by the time we realized in a fraction of the second, our access was lost. We just took a small puff and saw that the right coronary artery had a dissection starting from the ostium, which was type F, no antegrade flow, and we were literally in soup because we thought that we were going to lose this patient because of loss of access. So the first thing that we did was we went transfemoral, got a venous puncture and put a temporary pacemaker lead in, and then paced the patient at about 70 to 90 per minute. And then moment the pulse picked up, we got the arterial access and then took a shoot from the right femoral. As you can see that picture, Shantanu, you can play that for us. You can see the dissection flap right from the ostium extending up to the lesion. Of course, in this, I managed to cross the wire quickly in the mid RCA and then pre-dilated. Go to the next slide. So once we got the wire down the RCA and pre-dilated and established some sort of flow in the RCA, we were little comfortable and could breathe easy, and we didn't want to take a chance. We took a long stent, a 3x32, covering the lesion as well as the ostium from which the flap had originated. And once the flow was good, we post-dilated with a 3.5 into 15 millimeter balloon. So you can show the next picture. You can see here, you can go to the next slide, Shantanu. Yeah, play that. You can see here adequately dilated stent and good TIMI3 flow restored. Yeah. Can you go to the next slide there? We quickly got an echocardiography done to make sure that there was no pericardial effusion. The total contrast used was about 75 ml. You can go to the next slide there, yes. Patient started maintaining sinus rhythm. We switched off the TPI on table. The inotropes were slowly tapered. Patient was conscious and oriented with no respiratory distress, and then moved to the ICCU. Next slide, please. You can see the ECG immediate post-plasty because we kept the patient on table for about half an hour before moving to the ICCU. We did an ECG there where the STs had settled down immediate post-plasty and the ST depressions were also settling down. Next slide. So we shifted the patient to the ICU with the rhythm being stable. Echo showed no mechanical complications or pericardial effusion. The inotropes were tapered over the next 24 hours and patient maintaining adequate urine output and renal function. Patient was moved out of the ICU on day 2 and stabilized in the ward for 3 days and then discharged on day 6 of the procedure. Next slide, please. So that was the ECG post pre-discharge where all the STs are settled in a small queue in lead 3. The patient has come for 5-month follow-up now. No angina, no SOB, echo is showing still mild inferior hypochlorinacia. Patient on dual antiplatelet therapy and statin and doing well. So the learning points here, next slide. The learning points here, always anticipate the complication, however simple your case could be. Use a good guide catheter with adequate backup support, or if you need to deep intubate sometimes if you have to get down. Select your guide wire properly, whether it's a hydrophilic or hydrophobic. If required, use a 2-wire technique if you need adequate support. You should always know the entry techniques or re-entry techniques when there is a flap there to get into the distal vessel. And this was and sometimes you may have to use a negative suction if you need to get down the true lumen. Last slide, please. So it's an unfortunate but a well-known complication, having a iatrogenic guide dissecting the coronary artery, and it is more common in the AMI sittings. The clinical outcome is highly variable from good long-term prognosis to sometimes instant patient mortality because you could lose such patients on table. And a non-flow limiting coronary dissections are common with POBA. Sometimes we may even leave them off, but a type F dissection like what we saw is less common. And it could be sometimes guide catheter induced or even wire induced, and sometimes may require an additional stent placement, and very rarely some of them could require an emergent CABG also. Thank you for giving me an opportunity to present this case.
Thank you so much, Dr. Pai. That was an excellent, outstanding case. A lot of learning, managed expertly. Unfortunately, we are already over time and we have one more presentation. I'm quickly going to introduce the speaker. The speaker is Dr. Subrato Mandal, who's going to be presenting us a case from Bhopal.
Hi, good afternoon, everyone. Because last since 1 and 2 hours, 1.5 to 2 hours, we're seeing all the cases very complex. So I'll not take much of time. Just briefly, how we have retrieved a discharge stent. That is my case. So audible, everybody. I think audible. So my case is 63-year male. He has presented with effort angina, novel infection, 55% ejection fraction. LAD was mild 30 to 40% diffuse lesion. WM has the lesion of 80%. RC was non-dominant and normal. This is my angiography. You can see directly showing what happened started the problem. I do not restore the angiography. So here is the one where is in the LAD to stabilize the guide position. So after that, LAD where is then we have tried to, this is the lesion in OM2. So I have taken the crossing the wire with the support of balloon, and after that crossing the balloon, we have taken another balloon of 2 into 10 to pre-dilatation. So very simple case. It is not a very tough case, I believe, and everybody can finish it in 10 or 15 minutes. So after that, we have finished this balloon dilatation with 210. And after that, 2-3 times I've trying to take that directly. I thought it is a very simple lesion, so it is better to have with the stent. So the stent was taken 2.75 to 24, and then this now you can see the guide movement. See where I'm trying to push the guide, but it's very difficult to push. And while it is coming, multiple time attempted to position the stent in the in this location lesion, but unfortunately it has not been done. But when I taken out this balloon, the stent back, so I thought it's better we'll re-dilate that thing. So, but when once I observed that, what we could found is that there's no stent in the balloon. So balloon stent in the stent was been discharged. So I can see here we can appreciate very nicely that the stent has been placed across the left main to LCX. This also can be very nicely. You can see this. So after that, what we have tried to do is now what to do. Because suddenly it is intimidating this situation where now the patient also getting some bradycardia and some symptom, and you can see this which started bradycardia immediately after inotropic drugs started, atropine started, and then this you can see very nicely that we have tried to. Now we have one wire, another wire. We have options that we have that are my wire is in the place. So I have taken another balloon of 1.5:6 balloon I have taken. I have inflated across the stent. The problem is that it is stented, and again I just when I tried to pull out this stent along with the assembly, that only that balloon came out, but the stent is there only. I have but the accessibility is that the balloon stent was inflated, but it is stuck in the mouth of the guide. So I have to increase the size of the balloon. Now we have taken 2 into 10 balloon. It's the end balloon, and totally we have to cross the lesion, cross the stent part, and then part in the half portion in the stent and half portion in the outside the stent, distal part of the stent. And then after that, I have inflated the this stent, and then all the assembly I've taken out through the full assembly. And after that, of the assembly case, but suddenly I noticed in that there's no stent in the assembly. We could get this balloon, everything. So then after that, we try to search out where it has been dislodged again. So this is that I have gone through all, scanned all the body parts. Suddenly I could not find it where it is on. Then after that, we have seen that there's we are doing the left radial, and there's a small black portion. I've seen there is something is there. So they have focused. We have seen in the multiple views and some other different angles. So what we found is that maybe the stent which has been we have gone through all the assembly and are pulling out that was stuck in that mouth of the sheath. Then for confirming it, then we have taken another wire, and fortunately the wire has been crossed across the through the stent, and I was trying to manipulate and try to pull it through the sheath, but it was totally futile. So after that, I have done the multiple time I'm trying to triangle around the stent, but it is not, again, it is no results. So after that, we have taken a snare, 2.5 millimeter of snare we have taken, and very small snare, and try to catch it. Unfortunately, I wanted 2 wires and 1 snare, and after that, fortunately, we could get the stent edges. I caught it and taken out all the things out. So everything has came out, and this is the stent we could see here. How the distal part of the stent has been caught by our snare, luckily. So this has been taken out, and we have. So my take-home message is that dislodgement of the stent is not a very uncommon situation, and is a definitely potential complication of angioplasty. Calcific lesion are more prone to catch the stent. Always check for the stent in balloon, retrieve this with assembly, or many other techniques are seen by many other operators. Sometimes they take novel balloon techniques that another patient that's now. So thank you very much for your patience hearing.
Dr. Mandal, that was an excellent case. Dislodging a stent and then finding it is always tough, especially when you such a small piece of metal. It's difficult to find where it is. But it's a great case. Thank you so much for presenting. We are over time. Our colleagues from the next session are already here. Dr. Khanna, Dr. Bedi, Dr. Sumeshwar, I already see them. Thank you so much. I hope everybody enjoyed this session of complications. We are over time, so I will have to stop over here.
Yeah.
I would request all the panelists of the current session to log out, and so the next session can start of peripheral vascular disease. Thank you so much, everyone.
Thank you, everyone. Thank you for a wonderful session. Thank you, all the speakers.
Thank you.
To the audience, please bear with us. We are just transitioning into the other session, which is management of peripheral diseases with Shockwave IVL. Good afternoon, everyone. Thank you for joining the session on management of peripheral disease with Shockwave IVL. I'd like to call Dr. N.N. Khanna, who's the group advisor for Apollo Group of Hospitals in India, senior consultant and coordinator cardiology, cath lab, and vascular services. Good afternoon, sir. I hand over the session to you, sir.
Good afternoon, Shantanu, and thank you very much for inviting us. And today we have a wonderful panel. We are already late, so let me invite them. Let me invite Dr. V.S. Bedi to chair this session. He is a senior consultant of vascular and endovascular surgery at Sir Gangaram Hospital, New Delhi. And let me also invite a great panel here. Dr. Pramod Kumar, who is the director cath lab of Fortis Hospital, Shalimar Bagh. I would also be one of the panelists. And Dr. Atul Mathur, probably he was supposed to be there. Probably he's not able to join us because of some emergency. Now, the first speaker would be Dr. Tegbir Sandhu. He is a consultant interventional radiologist at Max Hospital, Mohali. And this would be followed by Dr. Vimal Someshwar, who is head of radiology and head of interventional radiology at Kokilaben Ambani Hospital at Mumbai. And Dr. Ashok Dhar, who is a senior consultant of interventional cardiology and radiology at Fortis Hospital, Calcutta. And Dr. P.C. Gupta, who is the clinical director and HOD of vascular and endovascular surgery and vascular intervention at Care Hospital, Hyderabad. This will be followed by Dr. Adarsh Tabra, who is a consultant vascular surgeon at Jaipur. And after this, it will be followed by, Dr. Rohit Nair would be the second speaker after Dr. Tegbir. And in the last, I would be presenting my case. And this will be followed by a discussion, which will be very interesting. So let me just invite Dr. Tejveer Sandhu from Mumbai.
Good morning. Good afternoon, sir. Thank you for the opportunity. Thanks to Translumina that I could be a part of the conclave today. Had it been any other day, any other meeting, and somebody would have said, okay, fine, you need to speak about some endovascular cases in the background of corona, the scene would have been totally different. But then, yes, the world is changing and we are looking at a newer set of things. And the 24th of May 2020, the corona looks something like this. This is not what we would know a few weeks earlier. So for the case today that I'm presenting now, this is one of the patients that we had done in the month of March 2020. The patient was a long-term follow-up, and we did an attempt to treat him using IVL, intravascular lithotripsy, using Shockwave. The patient one fine day in January gave me a WhatsApp referral. Doctor, this is how my feet are turning, my toes are turning black. The sequential images from January to 20th of February was something similar, and with exaggeration of findings. Now, the best was this patient had visited me on the OPD in the month of July 2019, wherein he was advised endovascular recanalization. A diabetic since 36 years with a poor glycemic control, borderline creatinine, post-coronary artery disease, post-CABG, hand presented with numbness and skin changes, left toes gangrene, and left lower limb critical limb ischemia. He was on an ongoing medication that was a cocktail of a huge list, as you can see for your own perusal. But then one of the key points in the history was patient a few years before visiting me had a trauma on the left leg, for which during the repair he had undergone a flap reconstruction of the left lower limb. Now, this is important because we weren't able to place where the ATA was. This was one of the bigger changes that we had. The CT angiography was done. It showed heavy circumferential calcium in bilateral femoropopliteal region and with a very poor below-knee runoff. On palpation, I could feel the femoral and popliteal, but the ATA could not be palpated, probably because of the flap. The plan of care that we could think of for this patient that we had come across was we would want to take an attempt at endovascular reconstruction or recanalization with a possible foot amputation as a step procedure. The endovascular recanalization was also planned as a step procedure, including 2 or 3 settings. The dilemma here, since the patient happened to have few contacts with medical people and happened to know a few colleagues of mine, was whether to use a plain balloon, or a drug-eluting balloon. Should I use a stent? Should I not use a stent? Should we go in for a bypass? Should we go in for an SVG graft or a PTFE graft? But then, yes, in September 2019 at CERSI, and then in February 20 in EVL, we saw the launch of Shockwave in India, and we finalized on using Shockwave for this patient. Having known Shockwave as an effective modality to treat vascular calcium, this was something that we could use, and this came across and we took him up. Now, considering this was the patient's pre-procedure angiography. If you would want to see those images, the SFA gets occluded in the adductor canal region with a very poor runoff seen
through the popliteal across the tibials. This was the angiogram done with us. These were the images with a clear-cut obstruction, diffuse disease, calcification in the lumen. We did the shockwave angioplasty as a balloon angioplasty would do. We did the full cycle of 300 cycles and did a reconstruction of the femoropopliteal artery. The result after the plasty, what we got was something like this. We had a good vascular recanalization with a good single vessel runoff, and we could see the difference in the two angiographies. Now, this was the post-operative, post-shockwave angioplasty images that we had. The pre and with a good below-knee runoff, not exactly a good, but then a better one that we got. The results, as I would say, the flow improved in the below-knee vessels. We also did a drug-eluting balloon PTA angioplasty below-knee, which was done 15 days later when the patient had come for toes amputation for the gangrenous toes, as you'd seen in the earlier ones. Now, 7 weeks follow-up we have for this patient with 3 toes amputated. Patient got a cycle of VAC dressings. The wound scar is healthy because of the lockdown. Now he's off the protocol of the plastic surgeon. The wound is healed, the bed is healed, and the limb is saved. The foot is salvaged. This is how Shockwave helped us in this case. Well, and this is where Shockwave played a role, wherein we had very heavy calcium in this vessel. So, in my opinion, here, when I say it was IVL was very effective. We did have a favorable outcome. Calcium in the wall was a demon that we wanted to handle, was very well accepted and treated. And the best part about Shockwave is it uses a low pressure balloon angioplasty. We just got away with a 4 millimeter inflation in the balloon. And yes, it was effective. The IVL, on the other hand, it is costly. The trick is the company Shockwave somehow restricts the number of cycles that the vibration cycle can be used, and you have limited sizes available in peripheral artery interventions. So that's my take and the case that we did, and my opinion based on the practical experience that we've had in my center, in a single center experience about Shockwave. And that's about it, keeping it short and simple. I would really want to hand over the mantle to the next speaker, please.
Tegbir, if I can ask you a question, great work. I think you did fantastic. That result is very nice out there, and you avoided putting in a stent out there, I think, with just using IVL.
Yes,
the only thing is that you did the PTA as a second stage. Why didn't you do the PTA at the same time? Because you would have straight away got a straight line flow into the foot at that particular time. Any particular reason for staging it?
We staged it because it wasn't planned in the first go, sir. We probably thought that we will be doing a Shockwave only. And an honest confession was, I discovered that the Shockwave lasts only for a certain number of cycles on table. So we weren't actually prepared for the DEB, and the patient who hadn't been counseled for that. So
no, just using a POBA would have been good enough at all, absolutely, in the BTK segment, because just going with a plain balloon, if you have, because the lesion was in the origin of the PTA, right?
Yes, sir. Yes, sir. So the lesion was at the popliteal trifurcation. Yes, sir. So would have done that. Yes, sir.
Just a short balloon, not even an IVL for this one, but a regular balloon would have.
A regular balloon could have helped. Yes, but then
subsequently.
We probably wanted to conserve the infrared because we were planning a step procedure, so we just delayed the thing.
Great. Yeah.
Yes.
Thank you, Dr. Tejbir. Please, if you could unshare your screen. Dr. Khanna is joining us in another minute. He some technical issue. If you could request Dr. Rohit Nair to share his screen and start with the presentation.
Hello, everybody. Can you hear me? All of you?
Yes, sir, we can hear you.
I'll just share my screen now.
Sure.
Can you see my screen, all of you?
Yeah.
Hey, good afternoon, everybody. Thanks for the opportunity to talk, and so many people, so many stalwarts here. I can see so many, and I can see also obviously one of my interventional radiology heroes, Dr. Somesha. So just going to quickly run through. My topic was on latest trends. I should be honest, I haven't used, I don't think the Translumina people will be very happy. I still haven't used the IVL, but looking for an opportunity to use it. So what I decided is to run through a few just very simple cases, which I've done for below-knee arterial disease, which is what I was asked to talk on. So we have got Mr. A, who's a 51-year-old. He was admitted on the 22nd of June last year with gangrene of the left big toe, ascending infection. The foot looked threatened. He's diabetic. He's got chronic liver disease. We did an ultrasound Doppler, which is what we usually do to start off with for any diagnosis. So that showed diffuse in the infrapopliteal arteries with almost nil flow in the anterior tibial artery. So that's his foot when he came in, and you can see it's quite infected. I don't know if you can see my pointer, but all that was actually quite soggy underneath. So that's from the dorsal, but you can see there's a bit of infection there. And that is the state of his foot when he came to us. So obviously we had an MDT. We discussed with the podiatry surgeons and the vascular surgeons as to what's the best way to go ahead. So we decided to do a crural angioplasty, which will happen on the 26th, and then depending upon the results, to go ahead and debride or amputate to see how things go. Can everybody see my screen now? I mean, can you see the video playing?
Yeah, we can see something happening out there.
Okay, yeah. So it's a bit slow, Dr. Wade, sorry. It's just coming up now.
Yeah.
We are generally a bit slow in Kerala, as you know.
You're super fast. You are the best guys. You got rid of COVID, yeah. You're the fastest.
That's true. So here we go.
Take away your credit.
So here we go. As you can see, it's anti-tibial, and that seems to be, I don't know how many people still practice angiosome principles, but I tend to, though I don't practice in principle, I tend to refer to angiosomes just to help me guide which artery to recanalize. And so he's had this, so I need to go through this quickly because I've got a few cases to go. So you can see that's a distal deformation via one of the peroneal arteries. I couldn't get through initially, so I had to, what you see on the screen is one of the Cook CXI catheters, which is a 2.67, and I used a 0.14 wire to get across. I still think, so that's you can see the catheter with the markers, where I've gone across occlusion. And then I haven't taken all the pictures. I just wanted to save some time. So I did a whole length. This is just plain angioplasty, which I still think is actually quite good in the below-knee arteries. I tend to leave the drug-eluting balloons towards the end as a last resort. And the initial picture was this, which showed some dissections in the segment. Usually, if the flow is good, I tend to leave it. But for this particular patient, the foot flow wasn't as good, so I had to replasty it. And this is a post replastying with plain balloons. So I'll just show you the foot runs quickly. And like it says, more antegrade flow in the foot. That's all what we wanted to achieve. Again, just so that's then obviously we got him back 2 weeks later. This is a completely team procedure. You have to have the vascular surgeons, the podiatry surgeons, the cardiologists to sort out the coronary artery problems. So he's come back to the surgeon for debridement. This is a few weeks later after debridement, as you can see. And this is on the 30th of September 2019, just 2 months later. And from where we started to what we have achieved is pretty good. And he was discharged on that day. The next one is Mrs. M, who's a 78-year-old lady with left dorsum foot infected ischemic ulcer, gangrenous third toe, and she's got respiratory diabetes. It was decided after an MDT to do a salvage angioplasty on the 1st of October and to be posted for debridement thereafter. This is the pre-angioplasty pictures that we can see. She had terrible disease, and she also was quite a big lady. The puncture was difficult, got through the puncture. You could see, this is the picture which I tried. She had an SFA. I think that was the picture first. She had an SFA, complete occlusion. But remember, all these are patients who are not in any way fit for surgery, or they do not have a good enough artery to do any bypass surgeries. So, we decided at the end of the meeting, and we just think, okay, this might be overall the best method. So we went ahead with an endovascular option. So you can see, you can't see much there, neither can you see anything here. But then again, I've saved it is just a simple triaxial system with a 6 French catheter, 6 French sheath, sometimes a 7 French sheath, 5 French catheter, and maybe a CX1 or Rubicon catheters with own 4 wires. So we managed to cross it. So I did a pre-angioplasty with a small balloon, the whole length. I'm just showing you selected pictures. Then with a 5M, 6M balloon of the SFA, and a smaller balloon for the popliteal artery. And this is the SFA had reclines to a certain extent, but the flow wasn't good enough into the AT, which is only runoff. So again, we went down with an own 4 wire all the way, went across the pedal arch. As you can see, the wire is into the plantar aspect of the plantar artery. And then we did a complete all through angioplasty. So that's the SFA, just to show you. It was a subintimal recanalization. You can see there might have been a small injury with this early filling of the vein there. And sorry, it's just, am I just going off grid there? So you can see the popliteal artery and the AT, which is recanalized. Again, this was just plain angioplasty. I didn't do any drug-eluting plasties or any of the other fancy new things, because I just wanted to achieve as to what we could best for this patient. If you look at the last picture, it isn't the greatest of this. I think there's a bit of spasm there, but I didn't chase it because we had spent a considerable amount of time recanalizing it. But it worked on. She had the amputation of the third toe and slough excision on the 7th November 2019, and that's the picture on the 4th of January 2020, where she's got good healing and she's back to normal basically. Again, I'm just going to quickly go through this non-healing wound. You can see tendoachilles tendon exposed completely. So the plan was for a salvage angioplasty before we do anything. She had renal failure, so I used carbon dioxide as a contrast agent, which I think is really useful. It's difficult to see, and as we get older, you stop seeing carbon dioxide. So I get one of the junior guys to take a look to tell me where they are. I used only 15 ml of Visipaque for this patient because his creatinine was close to 2.9. I'll show you the CO2 angioplasties. I think I know Dr. Vimal does a lot of these. And you can see the CO2 negative contrast going to SFA. It's not very clear, but you still can get enough pictures. At least you can save the contrast for the pre-angioplasty pictures. You can try and minimize the use of contrast by just using CO2. And then as you get along, you can see there's maybe something there in the popliteal artery, but nothing much flowing into the crurals. So let's just see that again. Yeah, so this is what I tend to do is, if you see the previous picture here, and I couldn't see anything, and I'm not a superhero and I can't, I don't have great eyes, so I don't take any risk. I just give a bit of contrast just to know where I am, just to see if there's any target artery I can chase. So that bit of contrast, about 4 or 5 ml, won't do much of a harm. This, I don't know what that shows. And yeah, so it just shows a wire, so I managed to get through the peroneal, which is the artery which I saw, and through one of these perforators, which is a medial perforator, I got into the plantar artery here. And that's the balloon inflated in the peroneal artery, which is what I wanted to recanalize. So that's you've got a bit better vascular flow, and then you can see there's now a good reformation of arteries in the foot. And what she had was a slough and tendoachilles excision on the 20th of August, and a split skin graft done on the 12th of October by the pediatric surgeons. Again, as it's a team work, and you can see soon after that she started healing well compared to what she had before. And that's a couple of weeks down the line. And then finally, this is the 3rd of December 2019 when we discharged her. I think coming up to the last couple of cases, Mr. SN, who's a 68-year-old ischemic left foot. I'm sorry, I've got my spelling wrong. He had rest pain. Ultrasound showed popliteal trifurcation disease. And that's what, and you can see how, I mean, the gangrene is ready, but it's all quite ischemic here. And just on the foot looks extremely bad. So we decided to immediately go for a salvage angioplasty because he wasn't fit for any procedure. And the 23rd of August, he had this very terrible disease. And I tried my best to get across from top, but then I couldn't. And hence, I think yeah. So this is in the foot. And you can see there's a distal AT reformation. So I thought I might try that to canalize. And you can see this is where I have tried to go from top, but didn't work perfectly the artery, and there's a bit of contrast in the center, and there's some contrast extravasation suggesting a vessel perforation. Hence, what I did is, he also, I think there are a couple of pictures which showed these are a mid-segment PT, so I cannulated that with one of those micro pedal sets, puncture sets, and used a 1/4 wire to go on top. And you can see this, it's in this is the chunk of the calcium, that's the subintimal plane I'm in, and that's a loop which I've formed. And then, oh, I'm sorry, I just think I lost that. Oh, I don't have these images, I'm sorry. So what I did basically is I went up with this retrograde with this wire, snared the wire through a 6 French sheath, and then passed a balloon from top, and did a plain angioplasty followed with drug-eluting for this particular patient, just because I had the resource to a free one, so I just wanted to use it. So I used that for this patient, and we managed to recanalize a posterior tibial artery. So this is what we achieved, and this is I think the final picture on the 21st of December 2019. He was discharged as such. I'm sorry I couldn't show you much pictures. So this is one patient where we had a slight difference, and we decided to, a patient who's come with a left foot abscess, decided to go for incision drainage of the left foot abscess, then an angioplasty, and further procedure as per results. So they took him to theater, and I just skipped that. The ultrasound, I just let you know, ultrasound showed chronically occluded infrapopliteal disease. And so on the 28th, he was taken for surgery, thinking it will be just small left foot abscess. But on opening, they saw the skin, soft tissue, plantar fascia, there was necrosed. So that has to be excised. And the flexor tendon sheets and the deep first intermetatarsal space is opened. And they had to take out the sesamoid. So it's more extensive than we thought it would. It didn't seem that clinically initially. It wasn't healing well, so the pediatric surgeons asked us for an angioplasty. So he had the angioplasty on the 6th of December, just 3 to 4 days after the procedure, or maybe a week after the procedure. So that's the picture, as you can see. Just run through it again. So I think it is a chronically diseased AT with not much. It's actually more of a collateral. But the peroneal, if you look at the peroneal artery, that seems to be the main artery and pretty chunky as well. And then we looked, and as you can see, the peroneal artery going through with multiple stenosis. And then we found, I looked back in his previous pictures, and I think he the patient with the peroneum magna and a chronically small AT. So rather than diseased AT, I think it's a chronically small AT with not much of a flow. So the peroneal artery was the artery which we needed to try and address. And as you can see, that's reforming into the dorsalis pedis with multiple stenosis within the peroneus. So the plantar aspect was quite bad. It was not, it wasn't healing well. So I thought it might be better to see if I can get the plantar arteries a bit more vascularized and then what it is, try and treat all that disease. So I got the wire, again using a CX1 catheter via the perforating artery into the plantar, and did a balloon angioplasty. Again, this was a plain balloon angioplasty. I haven't used a drug-eluting for this one either. So that's the balloon coming up. So that's from the peroneal. So I plastered all the whole peroneal, the perforating artery, and just into the plantar artery.
With what size balloon were you using in this case? Because you're going across the ankle.
Yeah. So what I did is I used a 2 mm. That is the smallest long balloon I had. I didn't angioplasty to its full pressure. I just did a suboptimal. I was a bit worried that I might.
Probably a 1.5 across the ankle would have been better. Or
yeah.
using a taper balloon or something of the sort, because 2 is a bit of an, sometimes can
But
be.
I think this was probably the posterior tibial was hyperplastic, and the peroneal itself continued as the posterior tibial around the ankle joint.
Yeah, must be rather than perforated.
I mean, I often find it very difficult to get it from the peroneal into the posterior tibial as a collateral.
Okay,
you tend to perforate and all, but I think this was actually original continuation.
Okay,
and
yes.
Probably helped you to get it.
Yeah, it is actually quite. Yes, that's true. Yeah, actually, the wire was quite easy to go in through. So it might be that, as you said, the peroneal is continuing as the. Yeah, I think that might be the reason.
Very commonly, yeah. Yeah.
So we can at that point we still would go below with a maybe 1.5 balloon below the ankle. Okay. So this one.
Yeah.
Good cases, I think. Very nice presentation, and I'm sure you spend a lot of time doing all these cases.
Exactly. If I can just ask him, Rohit, what was the choice of wire in all these patients?
So I used a 014 wire in most of the patients.
Which one? Any specific wire?
I can't. I mean, I've got a selection of wires here.
Okay. Are you using one of the CTO wires or the weighted wires or something of the sort?
No, the CTO wires actually. I mean, we have got the field FC.
Okay.
The field FC is not bad. I like it. The only problem with this, the moment you go across it with a calcium, that's it. It's gone. You can only use once.
Yeah.
Yeah. So
I think
Command
ES.
What's that, sorry?
Yeah. Command ES.
Command, yes. That's
Boston. Either a V14 or V18. Those
yes, Boston Scientific. Yeah.
Correct.
So my approach is, if it is a stenotic lesion, I use a Fielder FC or any of these hydrophilic wire. As you said, it can be used only once, so you can actually torque it very well and negotiate it. But if it's a CTO, then I would use any of these heavy-duty wires, either from Cook or even these wires from Asai. So some of these wires that I use for CTOs, Anyway, good presentation. Yeah, good cases.
Great cases, Rohit. Well done.
Yeah. So this is just after the this thing, and the split skin graft was suggested for this patient. I think I'll just have to skip because I think we're running out of time, so I'll just skip all this.
I think so. Yeah.
Sure. I haven't tried the Shockwave lithotripsy myself, but I know all of you know, but I've been kindly asked by Translumina to just show you some pictures, which I'll just quickly. So I'm just going to go straight to where we want to talk about is this catheter specifications. This is all what I was interested in. They don't have anything below 3.5 mm as yet, I think. Is that right? I think they only got minimum of 3.5 mm, but I don't think they have anything less than.
They haven't got the BTK segment right now.
Yeah, right now. Yeah.
They don't have anything in the BTK, only up to popliteal.
Okay, so I'll stop my presentation there. So the next speaker, and I don't want to take any of much extra time. It's a Sunday.
Yeah. Great.
Thank you all.
Rohit, excellent. You've shown some fantastic cases. Keep going.
Thank you. None of the backgrounds have changed. All of you. I've seen you in different webinars. It's all the same background. It doesn't change. Even Dr. Vimal's, I think, the same.
Yeah.
Everybody's working from home right now, so you really can't help it.
Yeah.
Yeah, that's true. Yeah.
That's right. Hi, Adarsh.
Thank you again.
So probably you'll have to switch off, Rohit.
Yeah, I'll just stop sharing now. Okay. Yeah.
So Adarsh is the next speaker.
Is it Adarsh or it's me?
I think it's Dr. Vimal.
Yeah, Vimal.
Where is it now? Yeah, got it. So you can see the screen, right? I suppose.
We can see a handsome face out there. Best I can say.
Okay, so guys, one of the biggest challenges that we have is across the joint, and over maybe 3 decades, we've been trying out various methods to answer this problem. And this was one such case which came to me, and basically I'll just show you the case. We know across the joint our challenge is the biomechanical force, and that the stents, if you put in there, they would tend to bend and kink and fracture, and that would lead to reocclusions. So we had to find out solutions in these kind of patients. So this is the patient actually. This is a 53-year-old male, diabetic, hypertension, tobacco abuse, typical presentations.
We can't see your screen, I think.
You need to share the screen. No.
Where is my share?
You have to share your screen.
You need to go down. There is a green.
No, there's no green on this. Let me call my daughter here. Yeah, she would help me out. Let me just call her. 1 minute. 1 minute. I'll just get it.
You can see the icon of share screen, Vimal, down below, right in the center.
Vimal has run away.
The screen share to karo.
Just a minute, huh? Just a minute, please. ये वीडियो दिखाने का है.
Dr. Vimal, if you scroll your mouse, you will be able to see a green button by the name of share screen at the bottom. The option.
No, that was not seen, therefore I had to.
Well, smart daughter is there, I can see her.
Yeah. बेटी है तो सब ठीक हो जाता है. Now?
Yeah, now you
can see.
Now you can just go on. Thanks, baby. Good job for your dad.
Yeah. Okay. So as I was saying that across the joint is always a challenge, and we tend to do a whole lot of things here. And the last thing that you want to do is place a stent here, though off late some new stents have come in which are promising. So this is a 53-year-old patient, typical history there, non-healing ulcer, very painful for over last 3 weeks. And I had seen him in around second, third week of February. He had absent popliteal pulse, absent DPPT pulsations. And even the right lower limb pulsations were very poor. And at that point of time, patient saw a vascular surgeon who went ahead, though this was not the original ulcer. This was after surgery, after debridement. You know, the debridement was done before any revascularization. So, which probably I thought was, not the right approach. I'm sure all of you would agree. At that time, the surgeon had performed an angiogram, and this is the angiogram from the right side. You can see the common femoral is occluded with large collaterals here, so entry from here was not possible. At that point, though the left foot was ulcerated and diseased, the angio was also done from the left femoral artery. As you can see that, this is the common iliac artery, and probably I think this would be where the bifurcation of the aorta and the right common iliac would come in. This is the left common iliac and the external iliac with hypertrophied internal iliac artery, suggestive of some disease in the common femoral. These are all the collaterals. And if you can see this picture, again was done by one of the vascular surgeons in Mumbai. There you can see the sheath from the femoral artery, and this segment probably was not considered and was thought that this segment existed. But I felt that these collaterals were there, so probably this segment was probably absent in the common femoral, and the puncture was beyond that, and that the retrograde angiogram was done. And this is a profunda femoral actually. The SFA is occluded, a lot of collaterals here. This is what I confirmed on my angiogram by doing oblique position LAO, and you could see that this is a common femoral, the external iliac artery and proximal common femoral, large collateral refilling here, and this was probably the CTO there, sorry. This was the CTO there, and distally, previously some stent was put in, the stent is occluded in the SFA, profunda collateral is reforming the distal SFA, and here you can see very slow flow in the distal SFA, Popliteal is occluded, the tibial origins are occluded, genicular collaterals here reforming it, and here you can see that the peroneal is forming the posterior tibial and going down into the foot. So in short, this was a patient who had a chronic CTO in the common femoral artery distally. It was across the joint. We had to think of a common femoral SFA junction to preserve the profunda collateral. Wound was in the PTA angiosome. As you can see, that wound was somewhere in this territory. I thought first revascularize and then plan the wound care. Access, then we thought of, could we go from the opposite iliac or femoral? Well, we had to open up the right common iliac artery and then do the procedure. So we thought we will go from the brachial approach. Our only problem was the device length of 135. This man was relatively tall. And we then decided if we get it across, we would do a drug-coated balloon across to the common femoral and the SFA. We would plan a drug-coated balloon here rather than any other device over here. So as you can see that, we took a left brachial approach. We took a long 7 French sheath. We did an antegrade. First, we attempted a subintimal approach with a loop. As you can see that, we took a Terumo wire and trying to get a loop across, and we felt, oh yeah, we are going down. We have crossed the lesion. But as we went down across the stent, we could not re-enter the distal SFA. So whole process is all waste, and we had to then think of something else. And at that point of time, we thought of retrograde femoral approach to get into the segment. And here we used a retrograde distal SFA puncture. We know that Tonasan had given us an idea in 1988 that this is a possibility. So we used an ultrasound guidance here under roadmap control or stent as a landmark. We could puncture the femoral artery. We were planning to puncture somewhere here to come in up here. This is the Cook micropuncture set. As you can see that a small needle with a 3 French sheath and a guide there. And this is a soft tip, but a nice support wire, the micro wire that is there with this, an excellent system. One should have it in the armamentarium in the cath lab. And sorry, how come this is not going ahead? Okay. Oh. Why is it stuck? Again, I may have to call my daughter here. It's totally stuck here.
Just click on the image again. It will start moving because sometimes the keyboard, you might have.
Yeah, I got it. Got it. The same plan. Yeah. So as you can see that we made a femoral puncture here and got a micro needle with a micro wire there. As you can see that this amount of wire, if it goes in and there is enough stiff portion here, you can actually track your guiding sheath and a dilator. And this is what was possible with the stiff support wire, which comes with the micropuncture set. So once we got this length of the wire inside, we got the sheath up and got a 4 French headhunter catheter up in the SFA, which went up with the Terumo wire. This is the segment where it was occluded. So our catheter from the brachial approach is sitting here. This is the segment which is patent but diseased. This is the short segment which was occluded, and we wanted to actually get a wire across here. And that's the time we used a Terumo wire loop technique to get. You can see that we are manipulating here with the wire, and one fine movement and the wire just got in. So the minute it went up, we were happy that we have crossed the lesion in the common femoral artery. And this is the loop method that we used here to help us get in. Once we were up, now was the question of getting this catheter up and a wire into the sheath. So we wanted to work from the brachial sheath. We didn't want to use the femoral puncture to put in a big system and have a big hole in the femoral artery. So this is what we managed. We directly cannulated the sheath here. I'm sure all of you appreciate this. This is standard technique, nothing new. We've all learned from our Leipzig colleagues. And there you can see that catheter sitting there, and now the wire has gone up here. And this was a 260 centimeter Terumo wire, which brought it out from the brachial and one end in the femoral. Once that was done, then it was a standard technique. We exchanged it for a 1/4 wire, as you can see that, and we took a balloon here and we plugged the puncture site in the femoral artery with this balloon at a soft atmospheric pressure of 4 atmosphere. We just kept it for some time, and some external pressure that helped us to occlude the hole in the femoral artery. These are pre-dilatation and post-dilatation with a 6 mm balloon. And finally, we got a drug-coated balloon. I think this is a standard procedure that we had achieved, and you can now see the flow in the posterior tibial into the foot improved. On table, patient got 50% relief of pain, and we felt that was okay. We were planning to probably recanalize the posterior tibial artery, but we thought since we have got a good flow in this, we will leave it at that. Maybe if the pain comes back or the wound becomes black again after debridement, we may do a popliteal artery recanalization here. We have to realize that since we are working from the brachial approach, getting a 150 length system was not available at that point. This is during COVID period we have done this procedure. So we didn't have 150 centimeter length wires or catheters. I mean, wires were available, balloon catheters were not available. So we did this plasty, and the patient pain within 24 hours came down, and patient was much better now. On Doppler, we could feel the posterior tibial pulse. The wound was cleaned and blood was seen coming out from there. And obviously, you are worried about the long-term patency in this kind of situation, but a drug-coated balloon probably across the joint is probably the best choice that we had. So this is what we achieved. Across the joint, the other options are atherectomy with DCB or just plain DCB. Or nowadays, we are using Supera also in quite a few of these cases. Some of these references are available, which we should always follow the experience of others. This is the LEVAN-2 trial, which showed that with the drug-coated balloon, there is a definite improvement in the outcome as vis-a-vis conventional PTA. These are some of the other references of percutaneous reconstruction across the joint, though they have done it for popliteal, and I have shown you the SFA. I think the things work in the same manner. Drug-coated balloon in angioplasty, femoral-popliteal lesions here, and LEVAN-2 trial, and atherectomy with drug-coated have been shown as good effective method, and we have done all possible of these techniques in the past. So I thought I will just show you how a retrograde approach, I think one should revascularize it before you do any surgical interventions, and probably a drug-coated balloon is a good choice across the joint. I would take up any questions or queries, and thank you.
Great, Vimal, great case. A couple of questions if I can ask you.
Sure.
One was when you did the retrograde puncture, what catheter did you take up from there? What was the catheter?
Okay, so as I said, we first took the micro wire and we exchanged it for the micro catheter system, and then we used a prograde catheter first.
We used a prograde.
Prograde catheter, crossed it, went across, and then exchanged it, and then went with the larger diameter wires and balloons.
What we generally do is either we take a Rubicon, or otherwise we just try to move up with the wire only and avoid putting in, and just keep a dilator, 4-fringe dilator, a little bit inside. That gives you support, because
good support,
here your main purpose was to enter the stent, and that's it. After that, you were able to cross. Now, number two is that the role of any kind of stents and all would only be there if you have one outflow vessel out here, because what we can see that down below the popliteal ends abruptly, and you're not seeing any collaterals, and all, you're only seeing collaterals, but you're not seeing a single named vessel out there. Am I right on that one?
That's right. That's absolutely right. We didn't have anything since we had used so much of contrast, and the pain went down. There were not many collaterals. So we thought if at all we needed, we'll come as a second stage to revascularize the popliteal. To come down to the popliteal, we may have to take a retrograde femoral approach, which I was a little worried because I was, I had done the angioplasty right at the joint here. So I didn't have a real good access to come down into the popliteal at this same time only. So that's the reason. And 135 length, we were not in a position to go down all the way up to the popliteal segment here.
So we are not
We
seeing
have
the
to go below knee also to open up segments.
Yeah, and we are not seeing any profunda. Was the profunda there or profunda was occluded?
No, profunda is here. This one.
Okay,
This is the profunda here.
Okay, and you don't
Once
want
I
to
opened this up, the profunda flow was much lesser. So direct flow through the femoral we could get.
Right, and you didn't want to put in a supera out there in this case because that's one choice which one is tempted at times.
Again, we had drug-coated balloon and all that has been used. Cost was another challenge. And since the pain had gone down, we were quite happy. We were ready with it. If necessary, we would have put a supera stent here, definitely. But this was not a flow limiting dissection. And these are the things which you will see with drug-coated balloons. You will never give a stent-like result in a drug-coated balloon.
Little bit of antegrade dissection on top one, and then down below you can see a little retrograde dissection. So there will be a few dissections. But anyway, probably has to leave them alone.
Yeah. I mean, it was something which we had to take a call on this at a point. But then we said, okay, since the pain has gone down and on Doppler on table, we could feel the Doppler pulse.
Secondly, the choice of puncture, you were very close to the stent where you punctured and all, because sometimes getting the right angle becomes a challenge out there.
Yes.
So would you have preferred to go a little bit more distally and then try puncturing, or you tried that and then came?
You know what? We were getting a vein on the way there.
All right.
So I didn't want to go through the vein and things like that. So we just went a little higher and we felt that was a good spot. We went in there directly.
Okay.
So vein was sitting very close by and we don't want to create an arteriovenous communication and then worry about it.
That would work like Veera Reddy's thing. Yeah, it will work.
Sorry?
I said that would work like the Veera Reddy concept of arteriovenous
visualization. Yeah, so the venous, yeah.
Yeah, possible. Just can I ask you one more thing quickly?
Yes.
The 7th French axis in the brachial artery. So you must have heparinized during the procedure. So it was just a routine manual compression and
yes.
Yeah.
Yes,
I
it's
always
a manual
worry
compression.
I'm always a bit worried with the brachial artery. But
yeah, it's always a big worry. Again, ultrasound is absolutely necessary. Your nerves are very close by. You can injure the nerve. And if you occlude the brachial artery, God bless you, because the upper limb will be a challenge because you have occluded everything there.
Exactly.
So we have had these problems in the past.
Yeah.
But what we are doing now is we are giving vasodilators during the injection and before removing the sheath.
Yeah.
And as you are withdrawing the sheath, when you are in the brachial artery, keep on aspirating.
Aspirating, okay.
Yeah. And, during the angioplasty anyway, we had given close to 5,000 heparin. So heparin, vasodilator before removing it, and aspiration and letting the blood flow out is one thing that we do. And when you remove the sheath, don't straight away push the pressure on it.
Okay.
Let little bit come out and then put a pressure on it. And always feel the radial artery before and after the procedure.
Yeah.
Keep a friendly vascular surgeon also.
Yeah.
Yes.
Yes.
Unfortunately, my friend is in Delhi. Yeah.
Brachial approach, something we've discussed earlier.
Yes.
Why not consider the axillary artery? Again, ultrasound guided over the humeral head works very well.
Yeah, PC, early days in KEM, we used to do axillary artery. We never did brachial artery in those days.
Right.
But in some patients, if you get bleeding, you will not know. The axilla will hold so much blood before the patient will tell you anything. So occluding the axillary artery, yes, I know 95% of the time nothing will happen, but even if 5% something happens, we will have a problem there.
So this is something which I saw just now, a few months back. I was in Munster and they showed a case of the Translumina, also the same place. When they do all their EVARs and TVAR, or their TVARs and all, or they do the branch devices, their standard approach is to expose the axillary artery, out there and then do all the procedures rather than puncturing the brachial artery. And then they just, close it and they feel it's much better because you don't have to take care of the bend, because once you get a sheath across and all, it's much easier to have, working.
Yeah, so I think open should not be a problem, but close.
Open exposure of the axillary artery for TVAR, for branch devices.
Yes. So open is definitely, you will close it and it's under vision. But when you do percutaneous and if you have a bleed there, God forbid. I mean, we have experienced it, this is like KM days. So I'm talking about 30, 35 years ago. And those hematomas are huge.
Yeah.
Those hematomas are huge.
So what we have changed is now we started puncturing the radial artery, or even sometimes the dorsal division of the radial artery, and you have this very good, sheets which are available, long hydrophilic sheets which are there, which come almost up to the brachial artery. And with the Merrill has got those sheets basically. So what we are doing is, in case we are not going to do any kind of, ballooning and all from top, and you just want a wire to cross line when you're doing a difficult iliac or something, we are using that approach rather than going across into the brachial. So that's much better. So learning from the, coronary, from the cardiology colleagues,
yeah, but
that I think works very well. And we do a very good puncture out here and the results are very good.
You know what, Bedi, in this case, since the lesion was all long SFA, I had to go all the way
case,
down.
I would agree.
The lengths were a problem. So radial approach was probably not a right choice. Iliac, I think up to iliac we can get over.
Another thing is here you have to do all your ballooning from top and not from down below. You don't want
Yes.
So you need access for that part.
Yes.
Entirely agree. But just for discussion point.
Yeah, I know. I think these are some options that probably in the long run, they will have long systems for peripheral coming from radial.
Correct. Yeah.
So I had some, observations on the brachial. We use brachial. Sometimes we don't want to use it every time. Yes, ultrasound guidance is a must. But apart from the thrombosis, a very common complication is pseudoaneurysm from there. So it's the technique, how you take it out and how you compress it is also very important. So you need to have a splint so that there is no proper bone behind. So there has to be a splint, and then somebody has to compress over the splint and then keep this compression for a little longer time, also palpating the radial and ulnar pulses. And this is, most of the time when you have problem is when we leave it alone to the nurses and you have.
Yeah, that's true. That's true.
So that's very important that we do it ourselves. And now we have started using percussion. So we tend to close the brachial artery by a percutaneous suture rather than to leave it alone to the nurses for compression.
I would beg to differ a little bit on that, Dr. Khanna, because I've been now using the brachial punches for the last 10 years. I would say the rate of complication is less than 1%. What is important is to get the, not take a greater than 6 French sheath across the brachial, and the puncture has always to be ultrasound guided. That is a sign going on. There's absolutely no discussion or anything, that happens on it. And then quite a few times when we find a high bifurcation of the brachial, so you see, that's when you end up, you can't use the brachial artery access over there. The other problem that happens is that yes, up to a 6 French, it's fine. But then my own criteria is that if the vessel is more than 4 millimeters in diameter, then I would safely go ahead and take a 7 French. Anything beyond that, I have absolutely no qualms in opening up the brachial. It's a 5-minute job. And, just stitching it up is, again, it's not that difficult. And
you need to be a vascular surgeon for that, Adarsh.
Yeah, but then, sir, the fact is that you see everybody who's here right now does have a vascular surgeon available in their center at any given time, all right? We don't have people who are working alone over here. So I think it's very important that if you are doing procedures like this, it's very important to have your backup. My cardiologist is a very good friend. So if I have a patient who's had an MI, I don't go ahead and do things for myself. I call him, I make him do stuff, and then I take over my job. If he has a problem, he gives me a call immediately. So yeah, of course we are there to help each other out.
Yep.
Great.
My complication rate as far as brachial punches are concerned, I would have done probably 250, 300 of them, is less than 1%. Not even that much.
Oh wow.
Good. Very nice. Chalo.
Okay, so then we move ahead. If there is no question, then we move ahead to the next one. And I'd like to invite now Dr. Ashok Dhar. He's going to be talking about endovascular reconstruction of aortic fistula with drug-eluting stents.
Where is my closure here?
Just to introduce Dr. Ashok Dhar, he's a terrific operator, interventional cardiologist, and radiologist, and he's the first ones to start angiography even for coronaries in the country. He goes in hospital, if I'm not wrong, and he's also probably one of the original trainees of angiography. Correct me if I'm wrong, Dr. Dhar.
Dr. Dhar needs no introduction.
Thank you.
Thank you very much, Dr. Khanna. It is nice to see that good old friends from Delhi are here. Dr. Bedi and Dr. Khanna. I believe Pramod Kumar is also there, who was during those days my associate at Batra Hospital. And let us start with this. This is something recently that we have started. And actually, this paper I presented first at your, in Delhi only at the Asia Pacific Vascular Society meeting in last June 2019. And it is on reconstruction of stenosed or occluded AV fistula for dialysis with coronary, everolimus or sirolimus drug-eluting stent covering the reconstructed vessel. From nephrology, it is actually this thing I found when I joined Fortis Hospital 2 years back. And there I found that they had a big nephrology unit with 40 dialysis bed functioning for 24/7. But a lot of complication I used to see there with AV fistula, occlusion of the AV fistula, and or narrowing, and the AV fistula hum was totally off. And then we sat together with the nephrologist and our cardiology unit and joint study, and we decided to go for, by this technique, reconstruction of the AV fistula. And we started this in October 2018 at Anandapur, Kolkata, the Fortis Multi-Speciality Hospital. It has a 40-bedded dialysis unit with 24/7 service, faces frequent malfunction of AV fistula, mainly shunt and venous arm. Short-term correction attempt, as we know from the history, ultrasound-guided POBA, but that is requiring repeat in 3 to 6 months very commonly. There is one perm cath implantation from cervical region, life also less than a year, and frequent risk of central vein thrombosis. The third is now AV fistula on other arm. You have to call the surgeon and he will do the same arm at different level. Deployment of wall stent was described in 1992 with Palma shots or wall stent, discouraged due to patency below expectation. 56% at 6 months, 48% in 1 year, and 20% in 2 years. It was published on 60 patients in a radiology journal in 1992. And nowadays, recently, I have heard from some other colleagues also, one from Indore and very recently from Sydney. They are doing practically the same technique as I am doing. And I presented this work with 26 cases, first in New Delhi on 26th of June 2019. The result of recent report on coronary stenting with recent generation of stents and advanced delivery system encouraged us to think about its application in this region. The other main cause was the grand reduction in price enforced by the current government that encouraged us to reconstruct the AV fistula with drug-eluting stent. Because with normal bare metal stent, the result was long-term was not very encouraging. And it is what we are doing with mostly everolimus and sirolimus, available length and size, suitable for arm and forearm vessels of Indian population, though these coronary stents. Technique is good old coronary angioplasty. Portal of entry is femoral if fistula is above elbow. 130 centimeters catheter we can approach with this. The second one is brachial. It is ipsilateral caudal, but I personally don't like this brachial approach. We were talking just now about brachial approach. We know from statistics, brachial and popliteal artery percutaneous approach, highest percentage of post-procedural bleeding. That is already published and that is accepted. So brachial artery, and here also, the pulsation of brachial artery is pretty high and the chances of bleeding is quite all right when we are ipsilateral caudal direction. We are doing the puncture, but it can be done, and we are now getting a 120 centimeters long guiding catheter, that is Judkins Wright guiding catheter, which I use in this case. And we can reach to the junction of, where the AV fistula was done with our approach from the femoral artery. If fistula is mid or low forearm, then the usual position. So this is how it looks. At extreme left it depends on the surgeon where he is doing the anastomosis. Low arm, then is the second one is the forearm. You can all see the anastomosis. And high forearm, there it is totally occluded. And also no feeling of shunt is seen. And there it is difficult to cross the lesion and enter the venous arm. So here it is the same thing as we do in the coronaries. That is, we enter through the brachial artery, through the radial artery after bifurcation of brachial, and we cross the lesion with a, I use simple BMW guide wire, and followed by balloon dilatation. They are usual coronary balloons. And then the last we see that this is quite common is the dissection of the stenos segment. And there it is preferably I take, that's why I like stent, and that looks good. And now you will be finding that there is no special balloon, no special guide wire, nothing, because these are the people who are having dialysis since years and all, and they are financially not that affluent. So we have to think about it. And previously, I think when I left India in 1913, at that time the stents were available in India, these everolimus stents, for 1.5 lakhs. And today it is 30,000. So it is within the approach of the general people. And that is what we should be thinking more and more, instead of using very costly material, particularly when we hear from Reserve Bank of India that next year our gross production will be less than zero. So here, after doing the balloon dilatation, we come along the arterial side and we enter into the venous arm and we deploy it, and that is the one can stent with tie. We can see that we have corrected the stenosis. And this is, unfortunately, I cannot show you. This is there's a video. Here we can see the whole length of the arterial and venous arm, and we can see up to the shoulder, up to the shoulder region, and it is beautifully, open the artery, and we can do the actually optimum documentation. Now, this is how we do the post-procedural treatment. Is ticagrelor I give 90 milligram twice daily, ecosprin 150 milligram once daily, and start dialysis after 1 week. And I give the suggestion to the nephrologists that do not puncture the stented segment. Now, there are colleagues who are doing this procedure with drug-eluting balloon, but that is very costly. And the patients from our Eastern India, they hardly can afford it. And this was actually the paper that I wanted to present. And now your questions, please.
Just one question. Great work, Dr. Dhar, as always.
Just a second, I
Regarding
cannot.
Yes. Treating with ticagrelor, there are a couple of studies which have come in which say that in peripheral, there is no advantage of using ticagrelor, and probably ecosprin and clopidogrel do equally well, and ticagrelor doesn't really provide any additional benefit. So any particular choice why you use ticagrelor?
Yeah, that is something that we are following in our hospital. Even for the, as I told you, we do the routine coronary system, and as we do the coronary artery dilatation and stenting, the same thing we follow here. And in coronary, in our hospital, we use ticagrelor, and that's why we are continuing it with it. But I have really nothing against clopidogrel and aspirin.
Yeah. The point is basically that in peripheral, whatever studies and all have come, have not shown any additional benefit of using ticagrelor. I agree with you that in coronaries, yes, definitely there is a significant benefit of using ticagrelor. But in periphery, there has been no, study which has proven that ticagrelor is any way better than clopidogrel or aspirin. So the only thing is probably the risk of bleeding becomes a little higher with these patients. Most of these patients are CKD patients. They already have, platelet dysfunction out there. So if they have a bleeding and all, then it becomes difficult to manage. They will be on dialysis. So managing those AV fistulas, sometimes the bleeding can be much more as compared to a patient who's on ecosprin, which we routinely give.
Yes, sir, I take your point, and this is definitely should be considered, but we are very carefully following these patients, and so far only one patient had a gastric bleeding, and that was corrected, and it is definitely, it should be taken care. I mean, one should consider this.
I think I have a question here. All these lesions that we are seeing most of the time are on the venous side, the proximal venous and close to the anastomosis. And our approach is always venous approach. Though we started our practice doing arterial approach, but now we are only going via venous approach. And I don't know how the other panelists are handling these kind of fistulas. It's always venous approach.
I didn't do even a single one with venous approach. It is all with arterial approach, and basically with the coronary arteries or cardiac things, I started doing in 1980.
Yes.
And yeah. And
no, we also started with arterial approach.
Yes, you can follow from my poor English.
Approach.
And follow from my poor English because I speak German.
Rohit, what is your approach in this?
I was in Hanover, and during the last days of Professor Grunzig when he left for Atlanta. Anyway, so
yeah, I just wanted to add on. Sorry, answer Dr. Vimal. Yeah, we have been always trained, and I've been always using a venous approach. It's just been more easier. You're more closer to the lesion, and you're more closer to the lesion if it's a venous approach. If you're going to space, I think you might as well get away with a venous puncture rather than doing an arterial puncture. And if you're coming from the common femoral artery, I think the control maybe at least for me,
difficult in the brachial.
Difficult, yeah.
Yeah, with the
PC
femoral artery, with the femoral artery approach, I would love to do all the patients by femoral artery approach. But problem is that the catheters are not that long. I mean, the length of the catheter is not available till now. We are supposed to get soon 120 or 130 centimeters guiding catheter, and then we can do all the cases from the femoral artery.
Second thing is you will need very, very long sheets and all in that case, because otherwise you will not really get much of support and all. If you go from the groin, the problem is that you need a very, very long sheet to go out there, a 90 centimeter sheet going across. So
Dr. Bedi,
PC, how are you doing?
I get your point.
Arterial approach, how many people are doing arterial? Khanna and Adarsh?
Yep, on a very routine basis. Very minimal venous puncture.
We do only venous punctures.
I have never done a venous puncture.
So here there is a probably cardiologists are still on the arterial side.
Because we are doing it since 4 or 5 decades. So,
but Bimal, we also have radiologists who are on the arterial side.
Oh yeah, I'm surprised. We started with that. Now, in fact, we are going into the jugular vein and then coming down.
Correct.
We're not even in the arm. We don't want to touch the arm area. You're coming from the jugular vein.
Usually the CKD patients are very bad arteriopaths. So you're coming from common femoral artery. You tend to have loads of other things that you come across. I just think it's probably much easier with a venous. It's just a personal choice, I think.
I think in the long run, probably we'll have to read up about this, either of these two approaches, and try and find out a solution. And again, the stent in this area, these drug-coated is definitely drug-eluting stents are probably the choice, but he's got a good shape and good curves from the arterial to the venous side. Long-term and these kind of things, you have to kind of assess that,
But I would still look at puncturing the vein rather, because it's right out there. It's superficial. Most of these patients with AV fistula, the veins are nicely dilated. If you're in a good segment and all, it takes you probably much less time, much less fluoroscopic time and all to address the lesion rather than going from down below.
I think all of us have our techniques of doing it. I think we just need to respect the way the other person has been doing.
We appreciate that.
People who've been doing it without any problems and getting good results, I see no reason why
only my concern is sometimes these stenosis are very tight and you need a high pressure balloons, and normally we end up Mustang, or even we've gone with the barred balloons to open that up. And number two, the veins is what you want to dilate. And veins, 3.5, 4 mm is not enough. When these veins are dilated.
I'm not at all questioning the justification.
We can post-dilate it. That is not the problem.
Have their own reasons.
Yeah.
Why are you trying to convert somebody when he's so convinced doing from 1980s and quite happy with it?
I'm not trying to convince anybody. I'm just saying we have to look at it, both the technique and see.
I think have both the options available.
They are for adopting yourself. That is why we adapt as surgeons or endovascular specialists, newer wires, newer balloons. If you say that I use the same balloon in 1990 and now if I'm using that's not a justification. My point is only that it's just making a point that if we can make a discussion. Fluoroscopic time.
Dr. Bedi, you were mentioning about the length of the catheter for the control. If it is the first time use of these catheters, one can control it very well. Just avoid reuse.
So the problem is all these patients who come with CKD, either way they spent all their money, and you can imagine that we have to do those angioplasties in less than 25 to 30,000 rupees. Because the patient has got a financial challenge, unless and until the patient is very well to do, you can use a lot of NY stuff. And most of them, the problem is they are all HBsAg positive. So, or HCV positive. So then the problem is basically whatever you're going to use, you got to discard it also. So I think one has to look at the practicability also of the whole thing, try to minimize the use of hardware and maximize the results with less, fluoroscopic time. I would look at as interventional people, we should try to reduce the fluoroscopic time to our maximum.
Yeah. Right.
Okay.
I think
good discussion. Yeah.
Great.
Thank you.
Thank you.
Kanna, your mic is mute.
I think it's better to leave the choice to the guy who is operating, and also each lesion has to be approached in a different way. Sometimes the arterial approach is actually good. Sometimes the venous approach is very easy and very fast. And we have an extensive experience, because 40% of my work is venous. And we have our biggest, renal transplant center for the last 5 years in the entire world. We do close to 600 renal transplants and almost like 300 dialysis a day. We see a lot of these issues. But I would agree, if I have a choice between arterial and venous, I would first go venous rather than arterial. But many a times, you believe you me, we have arterial, we have major advantages of going from the arterial side and actually being very precise in putting these stents or having good angiographic results. We've even tried going radial if the fistula is a little higher up, so you can approach both arterial and venous side, but of course you can't use big balloons on the venous side if you want to dilate. Now regarding ticagrelol, yes, per se in peripheral vasculature, it will have doesn't have that additional advantage which it has in coronaries, but also we need to remember once you are using drug-eluting stents, they very seldom endothelize in the first year or second year. They need a good dual antiplatelet strategy. And if you see the genetic resistance of clopidogrel in India, which we see very often in coronary practice, 20% of Indians would have a genetic resistance to varying degrees for clopidogrel. And that is why if you see most of the cardiologists have shifted their entire practice of dual antiplatelet to clopidogrel, to ticagrelol or prasugrel as a primary DAPT strategy, and then change it on to clopidogrel after 6 weeks to 3 months, depending on the time they are more comfortable. So I agree. I mean, not only that, the CRF patients, they are at high risk of bleeding, but they are also at high risk of restenosis, because in CRF, restenosis and stent thrombosis is also very high. They are also having prothrombotic conditions. So I think ticagrelol is not a bad choice, but again and again, you need to be very watchful for bleeding. And if this patient is very moribund, or this patient has a history of bleeding, or has a history of stroke, or is quite hypertensive, which is not controlled, then ticagrelol we should be used with caution. But definitely, in terms with drug-eluting stents, it has some role to play. Our practice is to use more of drug-eluting balloons. Cost issue, of course, is a big thing. But in our hospital, we never everything is new, and why we don't have ETOs for anything. So cost, that consideration is a different practice at our place, but definitely with drug-eluting stents, the endothelization is very poor and the risk of stent thrombosis is very high. In Indians, it's proved that 1 out of 5 would have a genetic resistance to clopidogrel. So with this, let's move on to other presentation, and this is by Dr. C. Gupta, and this is on the management of aortic aneurysm. Dr. Gupta has an extensive experience in endovascular and as well as open repair, so it will be very good to hear from him. We can't hear you, Dr. Gupta.
Yeah, I'm on now. Now you can hear me.
We can hear you. But yes, we can see you. You need to share your screen.
Yeah, I'm just coming to minimizing this, and unfortunately, my daughter is not here with me.
You're working from remote.
No, she's abroad. Just one moment.
She's still in Japan?
Yeah, she's in Japan. So I think my screen share is on and my presentation is here. Okay. So instead of talking about just how to manage aortic aneurysms, I think all of you know that. I thought I'll just share my experience of mycotic aortic aneurysms, dealing with them with the endovascular technique, because there still remains a lot of controversy as to how to deal with this entity. Of course, there is an option to do surgery and there is an option to go endovascular. It's uncommon and devastating, extremely high mortality. It arises basically because of the infection in the arterial wall, and patients typically can be quite moribund, coming fever and malaise. And then, of course, high TLC blood cultures may be positive. And of course, to confirm infection, you could look at CRP and procalcitonin, which would be indirect indicators. Doing a CT scan is usually diagnostic, and sometimes a PET CT may be required, which shows increased uptake of FDG in the infected area. Gold standard is open surgery, and this is the commonest form that we do use. Yeah, and in-hospital mortality with this can be to the tune of 20 to 40%. And EVAR has become an alternative treatment, sometimes as a bridging between the patient presentation and a definitive procedure. When the patient is very sick, there is a concern about keeping a foreign body in an infected field. Now, I'll just present a few cases. So this is a patient, 66-year-old. Came with fever and cough, and you can see the extravasation of contrast from the thoracic aorta. And this patient, we also did a PET CT, and you can see the increased uptake in the distal thoracic aorta. We started him on antibiotics. He was afebrile, and I think this is one of the things, if patients are afebrile, blood culture negative, it's reasonable to go ahead with a stent graft. So we put a Zenith thoracic device in this patient. And these are CTs during follow-up. At 2 weeks, we can still see some hematoma near the stent. At 3 months, it's virtually gone. We have almost a 5-year follow-up on this patient, doing extremely well. Now, this is another patient, a 48-year-old male, again a diabetic, came with fever and hemoptysis. CRP was elevated. He had had an endoscopy which showed an ulcer in the esophagus. Didn't seem to have an aortoesophageal fistula, though that was high on cards. So you can see the ulcer on the thoracic aorta. So he also had a TVAR using a Zenith device. And this patient has also done well during follow-up. And this is a CT during follow-up. You can see virtually no collection around the aorta. This was a slightly more complex case. This was a distal arch mycotic aneurysm. Again, a diabetic. Came with chest pain, fever, high TLC, procalcitonin was elevated. And you can see the aneurysm in the distal arch. So he had a hybrid repair. He had a total debranching from the ascending aorta, and then subsequently we put a stent graft. This patient also follow-up CT at 1 month. The aneurysm size has come down. He's afebrile. CRP levels have come down. This was a slightly different sort of case. A 55-year-old male came with abdominal pain, elevated ESR, and this was the picture that we found initially. It was slightly smaller initially, and we suggested surgery to him, and he disappeared, came in the middle of the night, and a rapidly expanding aneurysm. And I think there were certain issues with taking him for surgery because of his cardiac problem. So we decided to go ahead with stenting, which was the original plan. And since we had planned a stent for him, we had organized for a CP stent. And since that was available in the cath lab, we could actually put this in the middle of the night. This is the guide wire we just kept in the right renal artery as a marker. And you can see the stent here in place. He unfortunately died 3 months later following an acute MI. This is the second last case. This is a patient with tuberculosis. He had tubercular lymphadenopathy in the abdomen. And he presented with pain abdomen. And this was the saccular aneurysm in the descending abdominal aorta. Again, a very easy one to treat with a stent graft. This was a Medtronic device. And the last case, I think Vimal and Varinder must have heard this case earlier. This was an aortoesophageal fistula, 65-year-old male, came with dysphagia, upper back pain, giddiness, sweating. CT showed a saccular aneurysm of descending aorta. He was admitted with cardiology. We repeated a CT, and then after 24 hours, we got to see him. And the patient refused any intervention. Not much you can do except counseling when they are not willing. And we were sort of debating whether to go in for open surgery or an EVAR. And he crashed in the middle of the night. and sort of resuscitated, and we, as a sort of, we thought as a bridging therapy, we put in a stent graft. And you can see it's grossly infected. You can see pockets of air around the aorta. This was the sequence of events. We were very keen to separate the GI tract from the aorta so that continued infection would not be there. Again, consent issues and the whole thing got delayed, and finally we separated the esophagus day 9. The esophagus was repaired by the GI surgeon. He was hypoalbuminic, a lot of issues going on. The repair gave way. Not really fit for a gastric pull-up or any other procedure. Esophageal stenting was done to sort of try and keep the GI and the aorta separate. However, we lost him a month after the procedure. Follow-up, one of the patients, we had grown E. coli in blood culture. This was the patient we continued antibiotics for a couple of weeks before putting the stent. One was abdominal cox, as I mentioned. All these patients received long-term ciprofloxacin for 3 months. We have a reasonable follow-up from 20 months to 60 months, one in hospital mortality, and one sudden death following acute MI after 3 months. So there is definitely a changing trend in the management of mycotic aortic aneurysms, shifting from purely open to an endovascular approach. And while some studies have shown similar outcomes, others have indicated some advantage with the endovascular approach, probably because the procedure is less morbid. Long-term survival, re-interventions, and infections remain quite similar. And of course, I have to mention something about Shockwave. When you deal with aortic aneurysms and you have a calcified or occluded iliac artery, you can definitely use the 7 mm balloon to burst the calcium, put a stent, and then go ahead and deploy your aortic device. To conclude, EVAR is an acceptable alternative for treating mycotic aortic aneurysms with low 1-year mortality and probably in our experience even a lot longer. Prolonged antibiotic treatment could reduce risk of recurrence and need for open procedure in midterm follow-up. Any GI communication must be taken care of urgently. Thank you very much for your attention.
Great presentation, Prem. If I can ask you 2 or 3 questions. Please. You mentioned about the antibiotic protocol. So you said that you're giving ciproflox in all cases for about 3 months or so. Yeah. What about using parenteral antibiotics? Because one major concern with these patients with mycotic aneurysms is that they keep coming back. So generally our protocol has always been that we put the patient onto parenteral antibiotic for at least about 2 months and then continue oral antibiotics for at least about 5 to 6 months. That is what our protocol is. And then of course manage with all other parameters which are there and all. That's number 1 question. The second was the choice of CP stent. I guess that was more of an emergency situation that you wanted to get a bailout on because you didn't have any other stent, if I'm not mistaken. The third one on the case that the last case that you showed, we've had something similar to that a few times and all. And we did, of course, what we did was we did TVAR, and along with our thoracic surgeon, on the next day and all, we went out there and we just did the, gastric pull-up and all through a separate route and all that, and cleaned up the entire area and put a lot of muscle out there and all from there, from the latissimus dorsi. We basically, put it all over the thing and we were able to pull out this patient. So just these 3 key inputs, and if you could elaborate on those questions.
Yeah, going backwards, I think what you're talking about, the using of LD flap or any other reconstruction for esophageal fistula, I think done early on, these are probably good. And in our patient too, I think if we had done the esophageal separation earlier, I mean, probably the same day or the following day, treat that as an emergency, I think the result would have been very different. But I think once things got delayed and nutritionally he became poor, it really became difficult to do anything substantial for him. Yeah, choice of CP stent, actually we had organized this covered stent for one of the coarctations of aorta, where we thought, where the pediatric cardiologist who was doing it thought it might be a problem dealing with that risk of rupture. And there was a fresh incident fresh in mind from a few weeks back when the aorta had ruptured. And we were able to salvage the situation with covered CP stents. So this was available and we used it.
Yeah, because, in fact, just to share with you, a couple of years back at Samir Dani's meeting, new in Ahmedabad, Michelle was doing one case where this patient had a pseudoaneurysm in all of the iliac artery. And then it was a bit of a tailspin because the patient, I don't know whether Dr. Khanna was there or not, but he just kept on, he ended up putting in 3 of these stents. Vimal knows about that case.
Yes.
And eventually they had to give up because the leak kept on progressing. And eventually, I don't know what happened because on that day, it was quite a bit of a challenge.
No, Varinder, we had a patient where we had ruptured the descending thoracic aorta what the pediatric cardiologist while they were doing. There was a leak from the aorta while treating a coarctation. And we were actually able to salvage the situation using 2 CP stents. So it worked quite well. So I really think it depends on your situation and availability of hardware, it would matter.
I think the most important part is how healthy your zone of landing is, basically.
Absolutely. Yeah.
When you look at these saccular aneurysms and all, you don't know the bad aorta is much more, much longer than what you think it is always.
No, this was very stressful because the proximal neck was very, very short. And I wasn't sure how good the tissue would be at that level, very so close to the hole in the aorta.
Correct.
So
because
I was lucky to get away, but I think patient not so lucky. 3 months later, he did die. Coming on to the first question that you had about the antibiotic, I think what you are practicing is also a standard recommendation. And actually the recommendation, if I go by the textbook, if we are putting these stents or putting a synthetic graft in that situation, is 6 weeks of IV antibiotics. We found it at times it's difficult to manage it. We just tried, okay, let's give oral antibiotic and we give a slightly higher dose of ciprofloxacin. So as long as the patient is in the hospital, we do give IV antibiotics. And these patients, were at the time of discharge, we see that they are afebrile, the counts have come down. We have switched over to oral and they have done well. Recently, we operated one mycotic abdominal aneurysm. This was an open surgery and the patient had been febrile. And we've continued IV antibiotics at home also. So I think his total count and the presence or absence of fever seems to make a difference in what we choose.
See, the problem is basically many of these mycotic aneurysms come back to you after a few months, if not years sometime. So that is the major challenge that you can't, if you don't get rid of the infection completely, they may not come back immediately within a month or 2, but they may come back with delayed infection.
I agree.
These aortoenteric fistulas, especially in the esophagus, these esophageal stent, the problem is it slips off.
Yeah.
So to hold it back there is always a challenge, and the gastroenterologists, if they are experienced, they will not do that. There are tricks being done to hold the stent back in the position. Also, there are times when we get into the fistula and put a plug, we put glue. I know we're very messy, but yeah, these are some of the things which can help to close the fistula. Never 100% results for sure. And in an infected portion, having glue there and a plug there and a foreign body there is another challenge that you have. So people are trying various things, but as you said rightly, it's very challenging.
Vimal, I showed that slide putting that we put an esophageal stent more to tell you that I really didn't want it. I shouldn't be
exactly. That is what I mean. We also have put in before, we have done all these things. And we realize that the stent just slips off with esophageal contractions.
Yeah,
just goes down.
Some
there's
cases
nothing to
are
hold it back.
presented more to teach us what we should not be doing. I mean, this was a totally messed up case.
No, understandable.
I think we all learn from that.
Yes. These are all challenges which are very difficult to handle.
Using a very diplomatic word, I would call it something more like that, screwed up case.
Okay, so Khanna Saab.
We can't hear you.
I think Dr. Khanna is mute.
Okay, now I got it. We had a similar case of a mycotic aneurysm, and the guy done outside, and the guy had a tuberculosis, initially thought to be sarcoid, but ultimately turned out to be tuberculosis, had a aortoesophageal fistula. And this patient was more compliant, so we did a esophageal diversion, but we let the, and we had a pipeline, so the feeding was done through pipeline, and we let the fistula be there because that was the only source of drainage. And then our gastroenterologist did an endoscopic banding. And then subsequently, we put, after the patient was sterile, we put after about 9 months, we put a extension of the stent graft proximally and inside the first one. And that patient did well. But those are very rare patients who are compliant and give you time. Normally, these patients don't give you time. The second thing is, I mean, I read a lot of paper and research on the prognostic factors in myocardic aneurysms. Patients of myocardic aneurysms who present with fever and positive blood cultures don't do well at all. They have a very high post-op or a little early post-operative mortality. But patients who present with negative blood cultures and no fever, or even if they had fever, and if you can give the antibiotics prior to the endovascular treatment, they tend to be much better off in terms of prognosis. So these were the things which were consistently shown in the meta-analysis of many studies.
Yeah, I think I agree. If there is fever,
sometimes.
Yeah, please go ahead.
And if you can treat it first, if you can treat the fever and the infection first, and you have time, sometimes it is much better. You'll have a better prognosis. And the third thing is sometimes the fever could be of some indeterminate origin, and you have a saccular aneurysm. We are really not sure whether it was a myocardic aneurysm or it was just a saccular aneurysm with some other infection anywhere else in the body. And this sometimes is challenging. Looks like some saccular aneurysms would look like myocardic. They may not be really myocardic because they do pretty well and they have no issues after that. I mean, I like to take opinions of Dr. Bedi and Dr. Vimal, others about this sort of thing, because sometimes you are in a dilemma whether it is myocardic or it's not myocardic. You find a small little lymph node adjacent to that. You're not sure it's tuberculosis, there's a vague history, but there is a big aneurysm sitting next to it. And then you do stent those and you give them anti-tubercular treatment, but you're really not sure what happened there. So Dr. Bedi, I'd like to rich experience on this.
PET scan comes out there. If you do a PET CT, because if you find there are a lot of pickups and all out there in the PET CT, I think that's a good indicator that it is a myocardic aneurysm. And you always treat these as, especially when patients who present with multiple aneurysms, saccular aneurysms and all, consider them as myocardic unless proved otherwise. So I would say that probably you have to err on the side of overkill rather than underkill. And doing all the tests like CRP and all other things and all, including ProCal and all these things, they probably are an indicator. But I think the PET CT is probably one investigation which can really highlight if it's a myocardic aneurysm. That would be my take.
I think
it has a infected, slightest doubt, start a good antibiotic cover and do the whole procedure.
Absolutely.
I think that's a better choice.
And you see,
how common is tubercular infection as a cause of
commonly.
So when you are starting, I see most of us would start antibiotics but not consider tuberculosis as an etiology.
See, one more thing that we are seeing routinely now many a times is a patient who's undergone EVAR, being well on follow-up, coming back after 1 year, 2 years, or even 5 years, or even I had one patient who came back almost after 8 years or so, coming back with an infected endograft and all. So these are some of the challenges that you see, that some patients do manifest with delayed infection of the graft also, and that can be quite a bit of a challenge. And personally have removed, explanted 3 of these stent grafts, and it is quite a nightmare and all that sort of thing, pulling out these patients and all. So that's one thing which is there, learning from experience. Yeah.
I think it's quite similar to aortic open surgery, where patients can come quite late with infected grafts. They need not happen within the first few months or years. They even come back after 4 years, 5 years, 6 years with infected grafts. I think the same thing would apply to the endografts also.
One of the patients I've had, I can just share with you just more of an anecdotal case, which we had done is EVAR, a straightforward EVAR we had done along with the CHIM EVAR, in fact, we had done. And he presented after post-operatively after 6 months, he developed a giant, big seroma around the sac. There was no endoleak and all. So since it was a problem out there and all, we got our IR people to put in a pigtail. He put in a pigtail and drained out the whole thing and all, settled down and all, came back after some time again, and this time he came with a frank rupture of the sac. So treated with antibiotics and all, did very well. 6 months, 1 year later, came back with, florid fever and all those signs of, infection. So we were almost on the verge of going ahead and putting in, taking out, explanting the stent. The family just requested, okay, please try as far as possible. We don't want to, undergo this surgery and all, because naturally when you explain the risks and all, I said, we'll have a look at it. So what we did was we explored the abdomen, and we found that the stent was, we could visualize the stent and all out there. And there was a lot of muck around the stent, which we cleaned out, but fortunately the duodenum was not violated. We just cleaned out the entire thing. We put a patch of momentum, and this is now, I think, almost about 1.5 years or 2 years down the line. He's doing well. We kept him on antibiotics, IV antibiotics, for about 6 months. But he's a survivor for that matter, although he may come back. But I'm just sharing that these are the kind of cases also sometimes you have. Yeah.
Okay, so I think it's already 2 o'clock. So we have 2 more presentations. So I'm on call today. I'm actually getting a call from the hospital to let me present before others. And it's a small case on IVL. I'll just let me do it, then others will do it. In case I have to go, then I'll request Dr. Bedi to take over the questions and also take over my role. And otherwise, if I'm here, I'll continue the same. So I'll just go to my presentation. I'll share the screen now. Is my screen visible now?
Screen is visible, but your voice is cracking.
Okay, what about now?
Better.
Okay, so let me just start a quick presentation on intravascular lithoplasty. And in case you don't hear my voice, just give me a cue so that I can check it on my system. I'll start with intravascular lithotripsy, which is an IVL, which is a new treatment both for coronary and peripheral application. It is a localized lithotripsy to treat cardiovascular calcium, and this was inspired by the urological application, but now it's designed for cardiovascular system. For the last 30 years, we have been using lithotripsy, and we have enough safety data in kidney stone treatment. And here, the sonic pressure waves preferentially impact the heart tissues, which is the stone in case of kidneys, and disrupts the calcium, leaving the soft tissue undisturbed. Now, this whole system was then miniaturized and array lithotripsy emitters were used at the site of vascular calcium embedded on, and they were built on the distal tip of the catheter to optimize the treatment of cardiovascular calcium, which is the real issue when we treat this all over the body. Now, if you see a system, this is a simple system which has a generator, which is battery operated, so there's no need of external connections. It has a connector, which is simple and quick, and it is a smart magnetic connection to the main catheter. And it has a very intuitive design. The catheter has an intuitive design, and it runs over a 014 guide wire and used for PCI techniques. And it will deliver varying degrees of pulses. They are about from little to 80 pulses to 160 pulses. If you see the tip of the catheter, it is, for coronaries, it is 12 millimeter. But it is for peripheral, it is 40 to 60 millimeter. The balloon, actually, the nominal pressure is 6 atmosphere, but it can go up to 10 atmosphere. It has a distal and the proximal marker, and it has 2 emitters that pulse once per second. And there are about 80 pulses per second, depending on the use where we are using. When we do this lithotripsy, it's very important, you may do it for circumferential calcium as well as you can do it for eccentric calcium. But if you see a OCT demonstration of this calcium disruption, this leads to an acute luminal gain and also leads to a better compliance of these vessels, both in coronary and peripheral arteries. So you can easily expand this and put in stents and easily expand the stents properly. And what is very important here is this is hard for the heart tissue, and the shock waves are very soft for the soft tissue. So these are good enough to break the calcium. At the same time, they don't actually rupture the vessels, or they don't damage the vessels which are normal. I mean, the part of the vessel which is normal. Now, if you see on the coronary side, there have been various studies, the Horizon AMI and Acuity coronary calcium studies, the 1-year outcome of 6,855 patients. And what we found here, that patients who had moderate to severe calcium, they had higher death rates, higher cardiac deaths, higher MI, higher TLR, and higher MACE rates. And similarly, in peripheries also, the results are extrapolated and they are similar. Now, once we are doing and dealing with calcium, if we have an OCT or an IVUS, this is the best way to actually quantify the calcium, because many a times we are not sure, and we may think it's a very heavily calcified vessel, but it may not be very heavily calcified. And sometimes we may think that the calcium load is little, and it may be a very extensive calcium on intravascular ultrasound or OCT. Now, based on the OCT criteria, you sort of quantify calcium and score calciums on the angle related to the OCT catheter or IVUS catheter, the thickness of the calcium, and the length of the calcium, and you give points to it. So if you have an angle less than 180, you give 0 point. If you have it more than 180, you give 2 points. If you have a thickness of calcium more than 0.5 millimeter, you give 1 point. Less than that, it's 0 point. And if you have a length more than 5 millimeter, it's 1 point. And less than that is 0 point. And you have a score from 0 to 4. And this was published in the Euro Intervention in 2018. And what was seen here, with using this in coronaries, there was a direct correlation of stent expansion. And if you have an angle more than 180 degrees, you have 40% chance that this new stent would be under expanded as compared to angle which is less than 180 degrees. And if you had a thicker calcium more than 0.5 millimeter, the stent expansion would be just 35% as compared to 78% where it was not there. So whenever we are doing this assessment of calcium, both in coronaries and peripherals, what we have in our tool is armamentarium is a CT scan, angiography, and intravascular ultrasound. And on the table, when we are doing it, many a times when we are doing balloon dilatation and it's not opening up properly, we have a dog boning, and if we have a stent boost, you can actually then decipher the calcium much better. So you have to be intuitive what to use, and actually if you can assess calcium before we go in and with a stent, it's much better. So the tools are intravascular imaging by an OCT or ultrasound, or by angiography CT scan, or stent boost while we are doing our cases. So again, if you have a thick calcium, and if you have a calcium angle more than 180 degrees, and if you have a length more than 5 millimeter, what it requires is that you need to break this calcium properly. You can try non-compliant balloons, or you can directly go with IVL. Now, the IVL has one disadvantage, or I will not say one, not disadvantage, but a pre-requirement that the balloon has to actually track inside that lesion. And many times, because of calcium spur or because of tortuosity or heavy stenosis, it may not be possible. So in that case, you will go with a guideliner or a coronary technique. You take a small NC balloon and create enough space so that the IVL catheter can pass through. Sometimes it doesn't work very well, so you may use atherectomy and rotablation device, and once you are done there, then you can actually put in an IVL catheter and then try to use it for dilating these vessels. Now, in peripheral indications, the IVL has very unique application, like the case which Dr. Vimal showed. If you have to intervene in no stent zones, that means over the joints in femoral, in the groin or at the knee joint, you actually would like not to put in a stent there, but you would like to have a good balloon expansion. You want less of recoil. This is very important in iliac bifurcation, also important in popliteal bifurcation. Now, you may have some high-risk situations where you have bifurcation lesions, single vessel runoff, suboptimal use, and failed PTA. Again, it is very important. And it's very important before putting in a if you want to do an endovascular aortic repair or you want to do an aortic valve implantation and you have calcified narrow iliacs, you instead of endolining, you can use an IVL and you can actually take out the calcium, dilate these vessels, and easily go ahead and put in large bore devices. So these are the indications to use IVL in peripheral applications. We can use both coronary and peripheral catheters for peripheries. The only issue with the coronary catheter is it has a size from 2 to 4, but the length of the balloon, the treating portion is only 12 millimeter as compared to 40 to 60 millimeter in the peripheral IVL balloons. The diameters available are 3.5 to 4 and then 3.5 to 6 and 6.5 to 7. In 3.5 to 4, we have lengths only of 40 millimeter, but from 3.5 to 6 and up to 7, we have 60 millimeter lengths which are available. As opposed to coronary, where you have only 80 pulse cycles which are available. Here you have 300 when the length is 60 and about 40, about 160 cycles available when the length is 40. All these catheters, both for coronary and peripheral applications, run on a 014 wire, and they are compatible from 5 to 7 French. Usually 6 French is what we use. And the working length varies from 110 centimeter to 135 centimeter. So with this background, I'll just show you a case. It's simple. We had a calcified, this is a gentleman who's a diabetic, had 2 previous bypass surgeries, came for with acute coronary syndrome, had a tight, and also claudication, had a tight stenosis in the iliacs. This patient required both revascularization for coronaries and peripherals, and we wanted to use intra-aortic balloon pump. So we first took this patient for the iliac angioplasty. We did not want to, this is it was a very heavily calcified lesion. And what we did then was to take this patient to the cath lab, and we used with the pre-dilatation, we could get a balloon. And after that, we used our IVL balloon, and we had to give about 10 inflations and differential pulse cycles, and this dilate this. After that, we put in a stent, and this is the final result which we got, and this was good enough to continue with our angioplasty to the coronaries and using an intra-aortic balloon pump. So these are the pre and post results, and we just want to demonstrate that how these are actually transmitted and how soft it is. It is not going to damage anything. It does not create any ripple effect or vaporization in the cell line which we keep. And also I'll see if you keep it in your hands and then start giving pulses, it doesn't damage your soft tissues of the hand. So it is only hard on the hard tissues, but very soft on the soft tissues, and you can even use it on a chalk or a calcium in your hand, and you can see how it breaks. So this was just an easy demonstration. And I'm going to be stopping here, and if there is any question, I'll be very happy to take the questions. And others would have another talk after this case presentation.
So the iliac case that you showed, Dr. Khanna, good one. You didn't put in a stent in that one.
I did. After we could expand it, we did a stent, and we could easily expand that stent.
Used a balloon expandable one in that one?
No, I actually used a self-expanding, but there was some space at the bifurcation. I could easily put it accurately. The way we put it is we expand about, say, 10% of the stent into the aorta, and then leave it for about 30 seconds, and then slowly pull it back to the ostium. If we have space and we are doing it on the one side, and till that time we don't release the stent. So in that 30 seconds, what happened, the nitinol expands and it just fixes into that area, and then you can release the.
But is it as a routine?
The balloon expandable would be also a great choice, but we did not have that size at that moment, so that's why we used the balloon expander.
Yeah.
Definitely for precise positioning in an iliac, much better to use a balloon expandable stent.
Especially when you have so much of calcium out there, you are always a little concerned. But then sometimes if you need to put in long stents, of course, then Self-X is probably a better bet because of the budgetary constraints, I would say. Yeah.
And also I wanted to show that, the EVL works and it takes away a lot of calcium and makes the system.
Yeah, because now they're using it routinely for EVAR cases where you have a lot of calcium. So I think that works very well, and they have shown some good cases where they've done with the lithoplasty. They've gone across, they deployed the stents, and they didn't even have to put in any stents after that. Normally, you need to, buffer them up with a self-expanding or balloon expandable stent and all. But then in this case, I think they've done a lot of cases where they didn't have to do that. So that seems to be quite promising, I would say. Yeah.
So now we are quite ahead of time as it is, so I'll leave it to Dr. Adarsh Kabra, and I will probably mute for say about 5-10 minutes. There's a call from emergency, and then I'll come back if I don't have to go.
Yeah. Somebody else is there to present right now?
Yeah, Dr. Adarsh is there right now.
Acha, Adarsh is there.
Yeah.
Adarsh, go for it, man.
Adarsh, over to you.
Adarsh is muted
is
right
he muted? Can somebody
No.
unmute Dr. Oh, he's there.
And I'll just, that's exactly what I'm trying to do.
You have to share your screen with us. You have a nice sketch at the back. Can I ask you who sketches that?
Yeah, well.
You muted yourself again, Adarsh.
Yeah, sorry. So we were on a sibling trip to Rome, Italy.
Nice.
For I think 10 days, way back in 2015. And that's when we had this caricature drawn for the three of us.
Nice, very nice.
So that was it. Okay, so we're all I'm going to unmute myself. Yeah, now I'm good.
Good to go.
Yeah, good to go. Right. So thank you so much for this opportunity, and greetings from Jaipur. Me and my partner, Dr. Praveen, he's an interventional radiologist, and we do all our interventions together. So getting straight away. So this is a 78-year-old retired principal of a nursing college in Jaipur itself. And she had the standard list of comorbidities: type 2 diabetes, hypertension, CKD stage 4, creatinine of 1.9, 65 kgs in weight, clearance of approximately 25 ml per minute. All other lab parameters are within normal range. Now she came to us with a gangrene of the right foot, great and second toe that was dry. And she had a gangrenous patch on the heel, which is approximately 2 by 2 centimeters. And she was in rest pain. Bilateral femoral pulses were palpable, and the popliteal and pedal pulses were absent. This is the right limb that we are talking about. ABIs were not recordable. We had a duplex done on her. It showed occluded femoral artery with patchy flows in the popliteal, extensive calcification in the femoral and popliteal arteries. PTA and peroneal were both occluded. The ATA was patent, Tardus pavus flows with distal ATA showing multiple stenotic segments. 2D echo was normal. So looking at there's an inflow problem. The graft has to go right from the common femoral artery onto the antitibial artery. And even there at the distal segment, you see there was a stenosis. And I'll just show you that on the angiogram also. So considering all that stuff, the age, we counseled her for an IVL and also with a DCB to the femoral and popliteal segment. And, just do a POVA to the antitibial artery because that was the only outflow that was available. So looking at the initial angiogram, this is the femoral artery. Very stagnant flow in the proximal third and very diseased, extensive calcium. The mid segment was totally occluded, distal femoral artery was reformed. And as you can see in the end, I have a wire across just up to the adductor hiatus, not taken beyond it. Of course, we had to confirm that we had, normal re-entry, and we were in the interluminal plane, during our wire maneuver. The popliteal artery, as you can see, is very, very craggy, and there was no way in which I'd have taken my Termo across it first up. But then the anteritibial did look reasonably all right in the proximal segment. And if you can see my mouse over here, you see this distal anteritibial over here with a tight stenosis 1, 2, 3. And there was a very minimal runoff into the dorsalis pedis artery. So of course, we did an initial angioplasty with a 4x40 balloon to the entire femoral arterial length. And this was actually a prerequisite before we could go ahead and either put in the Shockwave balloon or even do an IVUS on this patient. So again, the wire, of course, was left, just before the popliteal artery disease. Didn't want to take my 3-5 wire across it. So once that was done, of course, we got an IVUS done, and this really demonstrates the extent of calcium. I'm going to run both these screens, both these images simultaneously. So on the left side is the popliteal artery, and you can see the lumen is small. There's an extensive calcification, circumferential calcification that is there, and even in the distal femoral artery. So of course, the calcium, like what Dr. Khanna was talking about, is more than 180 degrees. And we had IVUS that was performed to the entire length of the popliteal and the femoral arterial segment. So of course, this is done after the initial 440 balloon. And you can see the images run through, and I'm sure you can appreciate the calcium in this segment. So going to the next lot again, this is the mid-femoral artery and the proximal femoral artery, again, both running simultaneously. And you see the extent of calcium over here. Now, of course, I've been trying to get IVL, I think practically for the entire last year. And I was in touch with the guys in California, over mail for quite a long time. But unfortunately, they had no plan as to when they were going to release the Shockwave system in India. And as a result of which, there were a couple of patients who had to be denied this therapy. And, we had to convert them to an open procedure in which, of course, there were quite a few complications looking at the extensive calcifications and all that stuff. So anyway, so even in this patient, since we had the Shockwave available with us, so we thought that she was probably an ideal candidate to get a Shockwave, to blast off the calcium that was there. And, that is exactly what we proceeded with. And luckily with the patient and the family's consent, yes, we were able to go ahead. So of course, you can see the Shockwave balloon over here with these markers. There are 5 markers in it. That's 60 millimeter balloon. So this is a 560 Shockwave balloon. And like Dr. Khanna had said, we followed the protocol. So I'm just showing a few segments over here for want of time. I'm not going to be showing the entire thing. So of course, once the Shockwave balloon was inflated to some extent, then, kind of leveled it up further. So that signified, that the calcium was broken to quite a large extent and the balloon expanded rapidly. Now, this picture that you see is after the Shockwave and the DCB to the femoral popliteal segment, right? And this is the femoral popliteal, and this is the distal popliteal and the antitibial artery after, the POVA to the same had also been done. The rapid on-off of contrast, and please excuse me, we are working on a coronary system over here. So this was the, the end result. The gangrenous stores have not yet been taken out. I'm still waiting for the heel gangrene to settle down right now before I do anything to the toes. She's got a palpable pulse and the dorsalis pedis. One drawback, I think, in this case was that we did not do a post-procedure IVUS, which I thought that if you've done a pre-procedure, a pre-IVL IVUS, we should have done a post-IVL IVUS also, to identify how much of a calcium has been broken. But I think I had enough of being abused in a South Indian language that I did not understand by this elderly lady. And the angiographic results appeared satisfactory, so we kind of, gave the IVUS a go by. And of course, I feel that this technique appears to be a lot more physiological compared to TurboHawk, and the risk of vessel rupture is far, far less. And yes, we are looking forward to using it on more suitable patients. But of course, cost limits the widespread utility of this technique. But yes, where necessary, I think it is an absolute gem to be used. Thank you very much.
Great. Adarsh, just a quick one, that ostium of the SFA was fine, absolutely. I thought there was something.
So there was a dissection over there, and we left it because it was a non-flow limiting dissection.
Because I think I saw something out there.
Yes, there was a dissection in the proximal segment over there.
Okay, you didn't want to do anything to that one.
Yeah.
You didn't want to balloon that segment and all that.
No, in fact, for the popliteal and the distal femoral, we had a 5 mm DCB, and in the proximal femoral, we had a 6 mm DCB. So going, so we kind of sequentially upgraded in the proximal segment. That dissection was seen after the 4 mm balloon, recanalization itself. So that was the only thing that we could have done. And I'm not a very big fan of putting stents in these vessels. And since the dissection was non-flow limiting, so I thought we would be able to get away with it.
Okay, right. Great case, yeah.
A nice case, Adarsh.
Thanks.
Okay, so I'm back. Now, if there are questions, if Shantanu is here, then we can start with some question and answers, because we are already like half an hour over our expected time. If there are participants and there are questions, we'll definitely love to take those.
We had a good discussion on the entire...
Yeah, we actually had it all along, but I think there are a lot of people who have logged in, and
so I think
Richa was about to send me the question, but I don't see any of them here.
Yeah, I think we've had an entire spectrum of cases which have been there in terms of SFA, popliteal, and then iliac. So all the areas which can be covered and all have been covered. Along with that, probably looking at the indications for use in aortic aneurysm, I think that is one major thing which is there. Hello, yeah. So all these things, I think we have good clarity and all. I don't know. I don't have any questions. Anybody else has got any questions and all? Prem?
No questions. I think Dr. Khanna might be looking at the audience who might be sending some questions along with from the chat.
Yeah, nothing is on the chats and all. I don't think.
No, on the chat only we are there. The audience has a different link.
Tegbir, anything from your side in terms of this thing? What would you want in case you had a wish list and all that sort of thing? What would you want with IVL?
So IVL, I would want a longer balloon with much larger cycles that it should run in, with more number of emitters probably.
And probably what we would require is for the BTK segment, because right now we are limited, and if we have long balloons in the BTK segment, that would really make our life a lot easier. And it gives better results than a standard POVA, then probably that might be a good idea. That's what.
Very right, sir. And since the company has balloons for coronary, I guess BTK should not be an issue for them. They should be able to do it. Probably they should just launch it there with longer lengths.
I think that's one thing that
I feel that, you see, breaking the calcium in the BTK is not a very tough job. You see, the problem that happens is that we don't use the size of the balloon properly. If on preoperative ultrasound itself, if you determine, you see, looking at a luminogram and looking at the actual size of the vessel, they're two different issues. So if on the ultrasound itself, the vessel lumen is approximately 3.5, and doing with a 2.5 balloon, you're not going to achieve anything.
Agreed. But then the point is, sometimes you have these patients who have CKD with dense calcification. And that is where the challenge comes, that your wire goes through, but yet you are not able to take any balloon and all, or you still really got to take an undersized balloon, and even that one doesn't really inflate. And sometimes the balloon just ruptures and all. It happens very commonly. So that is the challenge, that probably in dense calcifications and all, you might require something better.
Yeah.
And probably this might just do the trick, provided the profile is not big. That's the only thing.
Agreed. So I have had that situation a few times, and we've got away using a rota.
Yeah, so I know that is there.
Yeah.
So we of course have the rota directional atherectomy device and all, but somehow it has not become very popular. And either ways, even the BTK segment, absolutely, there's nothing that which is really, rotablator or at the directional atherectomy hasn't done very well. I don't have any experience with using rota. Probably Dr. Khanna has some experiences using rota and the peripheral also. Dr. Khanna, do you have any experience on that one?
Yes, I do. But again, I would definitely say, although we have talked about atherectomy in a big way, the only thing which works better than rota is an optical coherent atherectomy. I mean, if you combine OCT with atherectomy, it works better. Otherwise, most of these things, they have a lot of trash. You may do a good, debulking and you can take over the calcium, but you still have a trash foot, and I don't like to do extensive rota and below-knee vessels which are heavily calcified. That's a critical point or something where I have to put in
the critical thing you can have, you can probably do it. Some discrete stenosis and all short stenosis, probably it might work, but not for when you have the entire tibials and all totally calcified and all. It's very difficult.
But you see, it is very rare to find dense calcification in the entire tibial. Invariably, it's a very small segment. That is involved.
Vessels, others you will see most of them with, you can see the.
Yeah, I think it is usually extensive in diabetic patients.
Yeah.
Okay, so there are some questions, and these were related to Dr. Rohit's case, Dr. Danesh Kamirkar. I mean, he had a question. Why not hybrid? Sorry, Dr. Vimal, why not a hybrid was considered like an open groin hybrid? Then once you revascularize, and then you can take care of the popliteal as well. But I believe Dr. Vimal is not with us.
Yeah.
So we can skip this, and I think most of the questions are for Dr. Rohit and Dr. Vimal. Both of them I don't find here. And so Dr. Bedi, you can answer. When should we re-intervene in that case which Dr. Vimal presented, if the popliteal needed to be opened?
Yeah, so that's what, it all depends on I think this particular patient, because they had already exceeded a lot of time and all, so that's why they didn't want to do it. But I think probably one needs to, depending on the condition of the wound and all, one would take a call in case the patient is not improving, patient has rest pain with a wound which is not healing. Then probably in this case, one would consider going antegrade from the groin now, because that part is clear now, and address the BTK lesion also at the same time. So I would consider probably maybe wait for a couple of weeks or something, let the patient stabilize, and in case the wound is not improving, then one would definitely consider doing something for the BTK segment, because this may not last on its own. Because right now you have a straight line flow going into the popliteal, and from there's practically just a leash of collaterals which are going. So you need to address it probably as soon as possible.
And then there is a general question: which hardware, balloons, wires would you normally use in below-knee angioplasties?
So below-knee, I think that's what we were discussing when I think Dr.
Rohit
was there. And we would consider probably using one of the CTO wires. We use the Command ES, which is our hot favorite, in fact, for that matter, or probably using a V14 or V18. Certain situations, of course, you need some weighted wires and all, and then probably a WIN, WIN wire is a good, WIN 40 or WIN 80 is a good wire to use. That is what we use commonly, but of course, each institution has its own preferences. I don't know what does others choose, because he's working with a cardiologist, so probably he has some. And again, you also, for that matter, you would be able to.
My set of hardware is totally different from what my cardiologist uses.
Okay,
so I have, my go-to wire is actually either the Nitrex 014 or the V14. And if it's a CTO, then I prefer to use a Rubicon along with that. It just crosses it like a gem. Correct. And if the Rubicon has gone, then the New York wire, the balloon will also go.
Right. So a lot of people actually, the Bombay group uses the micro catheter most of the time for crossing. Whereas with us and all, we use Rubicon only when we are going retrograde. If you are doing a retrograde puncture of the tibials, then instead of putting in a sheath and all, especially if you got a long lesion to cross, then we take a Rubicon, because that gives you good support with the wire and all. But when we are coming from antegrade from top, then in that case, what we do is we just take, if we have got a wire across into one of the tibials which you want to target, we just take a balloon and go with the balloon and wire combination rather than having too many exchanges. So, but like I said, many ways to skin a cat. So each one to what you are fond of doing. Yeah.
So if there are no other questions, I mean, if you permit, Dr. Bedi, you can close this session. And we had a very, very interesting session. Excellent.
Very interesting session.
I think I'll hand it over to Dr. Bedi, and he's probably going to wind up.
Thank you very much. I think we can just conclude, and gratitude to Translumina for arranging this thing together. And it's been some wonderful set of cases which have been shown by all operators and all, and I think covering up the entire gamut of from aortic aneurysm, thoracic, abdominal, and then going down into the iliacs and FEMPOP segment and BTK. So I think wonderful work, and kudos to every presenter out there, done great justice to the presentation. I think the audience which is there would have really benefited with all the interactions out there. I hope we didn't bore them to death. And thank you once again to Translumina for this thing.
Thank you for all the kind words, Dr. Bedi. Thank you, Dr. Khanna, for the session. Thank you all the speakers and the panelists. Thank you everyone watching. Thank you for making BIC such a success. We look forward to your participation in such future events. Thank you all.
Thank you. Chalo. Bye everyone.
Bye-bye.